Okay, it looks like we are live. Okay. Yes, we're live. Good morning, guys. Oh, all right. Hold on. Just when you think it's safe. Okay. Just relocate this a little bit. There we go. All right. Good morning. Good morning. Good morning, you guys. Everybody joining us online. Thank you for joining. All right. So you guys read chapter 4 between Monday and today. Any questions on chapter 4? Anything I can answer for you? No? Let me go ahead and get your scores. This is going to be on page 184 in your book, your white book. And of course, all of the answer sheet and the grading scale is on the last page 201 if you need to grade it. All right, Alexa, stop. Is Alexa here? Okay. Tanya, Kira, thank you. Carolise, do you have 2 and 3 for me? That's fine. Naraya, thank you. Christopher, do you have 2 and 3 for me? Thank you. Jada, Peyton,
90.
do you have 2 and 3 for me?
I have 2, not 3.
Okay.
80.
Thank you. Good morning. Let's see here. Alex.
2 and 3, I got 95 and 90, and chapter 4, I got 100.
Very good. Thank you. Jessica. I just came in. Welcome back. Rebecca. 95. Amy. 90. Fernanda. 94. Stephanie. Chayla. David. Ariana. And Owen. Got it. 95. Okay. Jessica, do you have 1, 2, and 3 for me as well?
Chapter 1 is 95 and chapter 2 is 100.
And 3?
Chapter 3 was 95.
Thank you very much. I appreciate that. All right. Any questions before we move on? Any questions? Okay. So chapter 4 went over body systems. There's 10 body systems, 10 recognized body systems, and basically think of them as collections. Okay. So each one of these systems does something different, but they're all required to keep you alive. So think of it like a car. Okay. Your car is a car, but it has steering. That's a whole system. It has brakes. That's a whole system. It has an exhaust. That's a whole system. And all of those things work together to make your car work better, to make it run. Can you imagine driving a car with no brakes? You can't even start a car with no exhaust. So everything kind of has to work together. We don't really think about it. We just get in the car and drive. That's kind of how we think about our body too. We don't really care about all of this. As long as it's all working, we're good. The problem comes in when something goes wrong in one of these systems. And when something goes wrong in a body system, it can affect all your other body systems in some way. Now, how it affects is going to depend on what went wrong and how we're treating it. So you need to kind of understand this, because if a patient has, let's say, osteoporosis, okay, so this is a brittle loss of bone density. So it makes your bones very brittle. So if somebody has osteoporosis, that may affect some of their other body systems. And one of the systems that it could potentially affect is the heart rhythm. So what does the heart rhythm have to do with bone density? Well, because your heart requires sodium and potassium to maintain a normal rhythm. That's what maintains the rhythm. Well, where do you think your calcium and potassium, where do you think your calcium is stored? Where do you think excess calcium might be stored in the body? In your bones. So if we have osteoporosis, it means that we may not have excess calcium stored anywhere. So in that case, we might want, on the care plan, we might want to see things like, taking the pulse every day, notify us if there's any abnormalities. Does that make sense? Good. So there's things that aren't going to be like obvious to you at first sight. A lot of times CNAs are like, what does this have to do with that? Why is this on the care plan? That's not what they're here for. But understand that under the surface here, everything is kind of interconnected. Okay, good. Makes sense? That's what I really need you to get out of chapter 4. So this is important to understand, because a lot of times out there in the real world, clinical places, CNAs sometimes will do really weird stuff. That doesn't make any sense to me, so I'm just not going to do it. Not understanding that there's a reason that task is on the care plan. We don't get to decide to do it or to not do it. Does that make sense? Good. There was one on Facebook yesterday. I meant to screenshot it and forgot to. But a CNA was asking, basically, is it okay to do this, right? Whatever this was, I can't remember what. Oh, give a back. That's what it was give a back rub. Is it okay to give a back rub? Now, there were over 200 comments on this, right? Is it okay to give a back rub? The nurse told me not to, but the patient was requesting one. So there's like 200 comments. So I go through the comments because I want to see what people are saying out there. What do CNAs think about this? And about, I would say somewhere around 75% of the comments were, no, you can't. No, don't do that. No, that's a massage therapy job. No, that's physical therapy. No, 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 no. Not a single comment on there was, did you look at the care plan? Is it on the care plan? Listen to the nurse who made the care plan. Everybody out there is just trying to decide, is this something we should do, yes or no? But nobody was referring back to the care plan or the nurse. Now, the nurse told her not to give a back rub. That should have been the end of the story. But instead, she goes on to Facebook to figure out, should I do this or not? My patient requested it. So understand that the things that I'm teaching you, they're true. They're right. We have to follow the rules. But out there, you're going to see a lot of people that don't fall into that trap. Okay. If this CNA is giving back rubs and the nurse said no, who has the liability for that? Okay. The CNA is assuming the liability for that. That's right. Because she's not following the care plan or the nurse. Does that make sense? So you're going to see out there, and I hate this, I really do. You're going to see out there that there is a competing dynamic between nurses and CNAs. They butt heads. There should be no headbutting here. If the CNAs understood their role, there should be no headbutting. The nurse says it, we do it. If we can't do it, we tell the nurse. I mean, it really should be that simple. But unfortunately, a very large percentage of CNAs out there have this twisted, and you're going to be working with them. And I bring that up because you need to understand what your responsibilities are. Okay, good. Makes sense? Okay. So we're going to take a quick trip down each one of these body systems, and we're going to discuss normal changes of aging that happen in all of these body systems, because the most common patient type that we're going to have is older. Okay, they're the ones that really need our help. Now, that's not saying that younger people don't ever have medical procedures. They do. They do. But we have to keep in mind that the majority of our patient population is going to be older. So understanding, what the normal changes of aging are will help us help them. So again, you don't have to take notes on this. This is just going to be kind of a recap from chapter 4. You can go back and rewatch this if you want to, but you don't need to take notes. However, I do want to say this. On the state exam, you're going to have 5 or 6 questions on the written test that have to do with normal changes of aging and what you need to do. Okay. So there will be quite a few questions on the state exam about this topic. All right. So nervous system, this is the one system to rule them all. We start at the top here. Your nervous system is made up of your brain and spinal cords and nerves. And this is your communication center. It relays information. And we're going to talk a lot about this a little bit later today when we get into foot care. Okay, we're going to talk a little bit more about how the nervous system works. So just kind of put that on hold for a second. But understand that the nervous system is the control center of the body. It's going to tell your stomach when to digest stuff. It's going to tell your muscles when to move. It's going to tell your bones when to store stuff and when to break it down because we need it in the blood. It's going to tell everything. Everything is controlled by your nervous system. But we have to think of the human body kind of like a factory. And this is the best illustration I can give you about this. So if I were to create a thingamajig, whatever that, let's say I create this thing, right? I create it, I want to have it produced, and I want to sell it. And I go out and I look for factories that I want to make this for me. I'm not making this in my basement. I don't have a basement. So I've got to find a factory. So I go out and I tour some factories. And I tour a factory that is 80 years old, broken down, busted. All the gears are rusty. It produces stuff, but maybe only half the time. And some of the stuff it produces isn't any good, but it still works. Not great, but it still works, right? And then I go tour a factory that is brand new, state of the art. Everything is computerized, super fast, super efficient. Which factory would I want to make my thingamajig? What's that? Yeah, the new one, right? Because it's efficient. Everything it makes is going to be good quality. It's going to do it fast. So I'm going to get more money, right? So I want that factory. Everybody on board with that? Everybody understand that? Okay. Your body is a factory. When it's young, everything works great. Okay. Straight off of the factory floor, everything's working great. As you age, though, every part of your factory ages with you. So your nervous system is where we create memories. Okay. It's your brain where we create memories. Now, the memories that brain creates when it's young are good memories. They're going to stick around forever. They're good, quality, solid memories. The memories that factory creates when it's 80 years old, those memories aren't going to be so good. They might be hit and miss. We may not be working at all today. We might remember something for a few seconds and then it goes away. So when we're working with older people, we need to understand that their memory making factory is old. It's not going to work all that great. This is why you can have old people who remember what shoes they wore to a piano recital when they were 12 and have no idea if they had lunch. Because the memory of that recital was made with a young factory, something that wasn't good quality. Those memories are going to stick around forever. But the memory factory that made the lunch memory, it's just not working today. It's old and rusty. So let's not get frustrated with our patients. Let's understand that their brain, their memory making factory is old. It's not always going to be as efficient as yours. So if Martha asks, what time is lunch? And they just got back from lunch, your answer is, Martha, you just had lunch. Are you hungry? Not, are you an idiot? You just came back from lunch. I just walked you back from lunch. Why are you asking this question? That's not how we should respond. Does that make sense? I've heard a lot of CNAs use that. That's horrible. We shouldn't make our patients feel bad for asking a question. Sometimes, if this system is really affected, like with dementia or Alzheimer's, you may give the answer, we just got back from lunch. And they may ask 3 minutes later, is it lunchtime yet? Are we going to lunch yet? We just got back from lunch. A couple minutes later, is it lunchtime yet? Is it lunchtime yet? Their memory factory is completely offline. Answer it as many times as you need to. Hopefully it'll engage at some point. Better yet, gets them interested in something else because they're kind of stuck. Okay. Good? Does that make sense? So we can have short-term memory issues for sure as we age. It's just because our brain is older. We can also have decreased senses. Now, I want to talk to you about this because this is a very common one. I'm getting older and I'm starting to recognize a lot of this stuff in me now. So, diminished senses. We're pretty familiar with the fact that most old people need glasses. That's pretty common. As you get older, your vision changes. Actually, the shape of your eye changes. Isn't that crazy? Gravity. It's all gravity. The shape of your eye changes, and that changes your vision. So you usually need glasses. So as we get older, something that you can read just fine, like a big board at the end of the bed on the wall that tells your name and the nurse's name and the treatment plan. The patient may look at that and go, I have no idea what that says. I can't read it. And you're like, but the writing is big. What do you mean? Their vision has changed. Normal. It's okay. Let's read it to them. Or make sure they have their glasses. Hearing is another one that most of us are familiar with. A lot of older people have difficulty hearing. That's a sense. It's controlled by the brain. And because the brain is aging, the senses tend to age too. What you never want to do with somebody who is hard of hearing, who has a hearing deficiency, is shout at them. Because when you shout, it raises the octave of your voice. You actually go up 2 or 3 octaves when you shout. So you can't hear well at higher octaves. It's actually the first thing that goes with hearing. What you want to do, instead of shouting at somebody that is hard of hearing, lower your voice and talk slower. Often they'll be able to pick that up. It's all about the tone that you're speaking in, not the volume that you're speaking in. Make sense? Don't shout at a hard of hearing person. Now, if they have one ear that hears a little better than the other, make sure you're on that side. We can help with that. But if I start shouting, my voice goes up an octave. It becomes more shrill. They won't be able to hear that very well. Taste and smell tend to go together, and like any other sense, it's going to be diminished as we age. What do you think this is going to do to their appetite? If you can't smell and you can't taste, what does that do to your appetite? Yeah, it shuts it down. Absolutely. One of my best friends just told me yesterday she's got COVID. She can't smell or taste anything. She has no interest in food at all. None. So that's kind of crappy, right? Because when you're sick, you need extra nutrition to be able to fight off the bad guys. So if we have no smell and taste, that can affect how much nutrition we're taking in. Well, do you remember on Monday I told you that there is something specific that happens to older people? Do you guys remember I said that the external body fat, the peripheral body fat goes away, right? So that means that more of their calories have to go to producing heat because that heat radiates away. You guys remember that? Well, if we have decreased taste and smell, but we need more calories, that can work against each other. Do you guys see that? So a lot of times your patients will feel cold even though you don't, because they're not getting enough nutrition to burn those calories to create the heat they need to create. This is why our temperature ranges are a range, 97.6 to 99.6, because your older individuals will probably be on the lower end. It's very common to have a lower resting temperature when you're older because some of that heat radiates away. Isn't that cool? Decreased coordination. I'm starting to feel this one, guys. So they're going to be at risk of falling because they're just not as coordinated. My brain might tell my feet what to do, but it takes a little while to get there. Okay? The travel is a little slower. Slower reflexes, memory impairment, and decreased concentration. These are all normal signs of aging in the nervous system. They're also, for the most part, problematic for you as CNAs because almost all of these requires your attention. So when we're feeding somebody or bringing them their tray, we want to make sure the food is still warm. So you got to get it there quickly. Remember, their taste and smell have been affected. You serve them cold food, they're not going to eat it. So we need to make sure those trays are passed quickly. We want to make sure that we're adjusting our speech so that they can hear it. We want to make sure that we're providing visual cues that are big enough for them to see. We want to make sure that when they're out of bed, somebody is with them so that they don't fall because of those decreased reflexes and decreased stamina and things like that. So almost all of these take our time and attention. So we do need to know these. Then we move on to the cardiovascular system. So the cardiovascular system is your heart and your blood vessels. The heart pushes blood out to all of the different areas of your body. The veins bring it all back to the heart to be reoxygenated and be pushed out again. So this body system, the heart and blood vessels, are all going to age as well. We're going to talk a little bit more about this when we get to foot care in a little while. But as this system ages, we're going to see decreased endurance. They just aren't going to be able to do things for as long as they used to do them. Higher blood pressures. I'll show you why that happens. Prolonged bleeding and fragile vein walls. So just the slightest bump against something can cause bleeding under the skin, what we call bruising. Have you ever seen an older person and it looks like their arm is just like bruises everywhere, like all these big clumps of red stuff under the skin? Well, that's because we don't have that layer of fat to protect us anymore, and we have fragile vein walls, and our platelets aren't working the way they used to. So you put all of that together, the slightest bump is going to cause injury, bleeding out into the tissues, and we're not really going to be able to stop it all that well. So we end up with big areas of blood under the tissue. Respiratory system. This is your lungs, your breathing apparatus. Again, changes of aging, things get stiff. So we get less lung volume. You just can't inflate those lungs the way you used to. And you'll hear older people say this, especially in this heat and humidity. I'm really having a hard time catching my breath. Oh my gosh, I can't get a deep breath in. That's because of decreased lung volume as we age. Less endurance, for sure, and shortness of breath can happen as well. These are all normal signs of aging. Somebody asked, let me see if I can answer this for you. How do they know that the food is cold then for them not to eat it? Well, when you're serving something, certainly, you know, if I bring a tray to you that has food on it, you can see if steam is coming off of it. You can smell, you know, even with decreased smelling, that's going to play a part in your appetite. But if you bring somebody like scrambled eggs, let's say today that I serve scrambled eggs and toast, but I got it to you a half hour after I made it. Would you eat that? Probably not. I mean, it depends on how hungry you are, but probably not. It's probably not going to be all that appetizing to you. So how quickly we develop or deliver those trays is going to be important, and it will affect our patients' interest in eating. So shortness of breath is going to be very, very common with your older individuals just because of that decreased lung volume. So just walking to the bathroom might get them short of breath. That would be an observation. What do we do with observations? Report it to the nurse. We don't, even though we know that that's kind of normal for aging, we don't get to make that judgment. If we notice it, we always report it. Endocrine system. This one is affected a lot as we age. This is probably, I would say this is probably the most affected body system as we age. And it's one that most of us know nothing about. Now, your endocrine system produces hormones. When I say the word hormone, you're probably thinking testosterone and estrogen, the sexual hormones, because that's what always comes to mind when somebody says hormones. But your body is made up of way more hormones than that. I mean, that makes up like this much of your hormone production. But we have a lot more hormones in our body. Now, the hormones are what regulates everything. So your pancreas produces insulin. That's a hormone. Your pituitary gland produces hormones that help with your sleep and wake cycle. Your thyroid produces hormones that regulates your metabolism. Your adrenal glands produce hormones that regulate how much water you retain. So your hormones are running the show. And they're unfortunately things that we don't really think too much about. They are affected by aging with decreased hormone production. And that usually leads to sleep disruptions, decreased bone density, and reduced metabolic rate, among other things. This is going to be important to you if you work with the elderly population. Because well, let me ask you this. How many hours a night do you guys sleep? 5? How many of you can't get by with less than 8? Anybody? How many are somewhere between 6 and 8? Okay. All right. How many like 10 or more? Yeah. I like sleep. Absolutely. All right. A lot of your older individuals will sleep 2 or 3 hours. They just can't stay asleep. They can't get asleep and they can't stay asleep. So an older person wandering around the hallways at 3 a.m., very common. Very common. And it makes CNAs mad. Oh my gosh, I just put them to bed. Why won't they stay in bed? And we do things like putting up the side rails to keep them in bed. They don't need as much sleep as we do. They have endocrine system disruption due to aging. They need to be able to wander the hallways at 3 a.m. It is not your job to be their jailer and keep them in bed. They are not going to require the same amount of sleep you do. So it's important we understand that so we don't get mad at them. We get them up at 3 a.m., give them an activity. Okay, don't fight against it. Roll with it. Urinary system is also affected. You're going to have decreased bladder capacity. It's just not going to hold as much. You're going to have incomplete emptying. So when you go, you're not completely emptying. Now, if we have a bladder that's not holding as much and we're not emptying it, that means frequent trips to the bathroom. So your patient might ring call light, got to go pee. You take them to the bathroom, you help them go pee, you get them back in bed, get them all settled down. 30 minutes later, got to go pee. It's not their fault. Their body has aged. So should you give them attitude? No, just get them up and take them to the bathroom again. Decreased muscle tone and controlling the stream. This is very common with women. We see this as incontinence. Very common to have incontinence, urinary incontinence with women of a certain age, just because the muscles that control that stream just aren't very strong anymore. They can't hold everything tight. With men, we see the opposite. So women, they're incontinent. They kind of go. With men, they have trouble going. With men, a lot of times it's hard for them to start their stream. Okay. So with women, you might be cleaning them up quite often. With men, you might be standing there a little bit while they get things moving along. Okay. Understand that these are normal signs of aging. It's still an observation. We still report it, but you need to know that this is fairly common.
You mentioned all these things about normal aging, and then things that are beyond their control. And then when you add to that the fact that the physician may be prescribing something to intensify that when you're talking about the restroom, for example, you have a physician that's prescribing a diuretic, well, on top of the patient's body changing naturally, you have something forcing them to excrete more.
Right. Right.
So
We're going to talk about that in just a minute. Yeah. And you're absolutely right that treatments and medications will affect all of this, and sometimes in ways that may not be readily visible. Okay. So we'll get to that in just a second. All right. So integumentary system, this is what we actually see. This is, you see older people with gray hair or white hair. You see the wrinkles. You see the decrease in fat. You see the big blotches, right? Those are things that we see. So the integumentary system, this is kind of the visual signs of aging. We get thinner, drier skin. Well, if we don't have that fat layer to protect us, and we have thinner, drier skin that's prone to being torn or scratched or scraped, and we have decreased bleeding, this is where skin tears come in. And skin tears that are difficult to stop bleeding are very, very common among the elderly. So how should we handle the elderly? If we know that their skin is thin and dry, prone to tearing, and they don't have very good buffer layers, how should we handle the elderly? Yeah, gently. Absolutely. Very gently. So the way that you would move a child is actually a little bit different than the way that you would move an elderly person. So we're very gentle with children. We don't tend to be as gentle with elderly people, and we actually need to be more gentle with the elderly than we are with children. Does that make sense? Brittle nails we talked about. We did talk about that. I actually had to cut mine off a little bit more because it was splitting again. Decrease in subcutaneous fat we've talked about. Changes in hair color, decreased hair production, and darker pigmented age spots. Now, I always laugh at this because the melatonin in your bodies, when you are young, it kind of does the right thing. It goes where it's supposed to go. But melatonin, when you get old, man, it gets all kinds of confused, and it tends to clump together in places that you never had dark spots before. It's just like instead of going where it's supposed to go, they all just kind of clump together. And your patient will notice this. This will affect how they view themselves. This is a big impact. All of this is a big impact on their self-image. So you'll hear people complaining about this. You know, oh, my hair never used to be like this. Or I've got so many wrinkles. Or, wow, I've got these age spots that are showing up. Is this normal? Is this okay? Remember, we don't answer that question. I'll be happy to refer that to the nurse. Reproductive system, this kind of goes without saying. There are always changes in the reproductive system as well. Hot flashes and night sweats are very common in the aging population. So that means that we may have to change the sheets more often. Hot flashes and night sweats. Decreased moisture production. This is kind of interesting. When you go outside and it's really hot out there, what does your body do? Sweat, right? Sweat. And that sweat is essentially to keep you cool. Well, if we have decreased moisture production and our oil glands are not working as well, older people are at risk outside because they may not be able to sweat enough to cool themselves off. Remember, they also don't have that fat layer that protects them from the elements. So when we have older individuals, we need to understand that really hot temperatures may affect them more than you. So we want to watch them for signs of, they're faint, they're pale, they're sweaty. They just, or not sweaty, super dry when they should be sweaty. Those are signs that they're not acclimating to the heat very well. Do you guys remember back, I think it was 2004. No, you guys are all young. We had 3 hurricanes that hit Florida that year, one right after another. Boom, boom, boom. And it took out a significant amount of power to nursing homes. So a lot of these nursing homes had no power. Hurricanes usually happen in the late summer, early fall. It was super hot, super humid, no AC, no power, no nothing. We actually lost a lot of patients in nursing homes because of the heat. So one of the rules that was in place after that, the legislature went to work on this, and now every nursing home is required to have a generator on site that is capable of sustaining that building for at least 7 days without power. And it's because of this, because this actually killed people. Yeah, it was super sad, super sad. Of course, we have erectile dysfunction. External skin can become thinner and drier, so we have to be very careful when we're washing areas, and decreased fertility. Gastrointestinal system. This is the mouth, the esophagus, stomach, intestines, liver, colon, all of that. Digestion slows down. Very common with our older individuals. They want their bigger meal early in the day. So what you and I would consider lunch, they usually will have their bigger meal at that time. And then dinner, they just eat a little bit. A lot of older people adopt this eating style because the digestion just slows. And when they try to lay down with a really full stomach, it might move back up and cause acid reflux, or they may not be able to sleep just because they feel so full. So very common to see larger meals earlier in the day because that digestion slows. That slow digestion can also lead to constipation, and your patients will be absolutely obsessed with their bowel patterns. So lots of fluids to help that along, and anything that you notice, report to the nurse. Esophagus muscle tone diminishes. This is real. Patients that never had problems swallowing before, all of a sudden now they're choking on water, and they can't figure out why. And it's just because that esophagus, that muscle tone, has diminished. Decreased nutrient absorption, so they're not going to pull as many nutrients out, and they just don't get hungry and thirsty as often. Musculoskeletal system, you get decreased bone density, reduction of muscle mass, decreased strength, inflammation in joints. It's called arthritis. Arthritis makes things very painful for your patients to do. Arthritis is probably the main reason you're there to help them. Probably the main reason you're there to help them. Instability and coordination impairments are very common as well. Lymphatic system, this is a system nobody knows anything about. It's the recycling system of your body. It pulls in excess fluid that's where it's not supposed to be, cleans it up, puts it back in circulation. It's the recycling system of the body. The lymphatic system plays a huge part in your immune response. So if we don't have a good lymphatic system working, what do you think that means for our patients and their ability to fight off infections? Yeah, they're going to be sick more often. They're going to be susceptible because they don't have a good system in place to fight off those infections. Good? Questions on any of those? All right, so what we've talked about are the normal signs of aging, but remember that these don't affect everybody. There are lots and lots and lots of older people across the street in the housing development, and they have, oh no, I'm so sorry. I hope you feel better. Are you okay to drive? Okay, all right. Hope you feel better. All right, so all of these are normal, what we call normal signs of aging, but understand they don't affect everybody. Like there's a whole bunch of people in their 80s and 90s living across the street. They live in their own house. They take care of everything themselves. They drive their little go-karts or golf carts to, bridge and to play tennis and to go to the community center. I mean, they're very active and they may not be affected by all of those signs of aging. This is very individual. Okay. But we're not really working with that population too much. They don't need us. Everything's working well. They're still healthy. They don't need us. The people that need us, the people that need help, will probably be suffering from those conditions of aging. Okay, but remember, it doesn't affect everybody. Now, everything that we talked about can be worsened or made a little better by treatments and medications as well. So we may be giving a medication to help somebody breathe a little bit better by removing a lot of fluid, but that means they're going to have to pee a whole lot more. So remember that every body system can be affected by medication and treatments as well. Okay, so we learned pulse. Oh, good. Thank you, David. I appreciate that. Okay. Good morning, Sharon from Kenya. Okay. David, when you come back to class next week, I'll get your test scores. Okay, so when we're taking a pulse, we're always going to support the arm. Pulse is always measured over 1 full minute or reported over 1 full minute. How long we count will depend on the care plan, but it's always reported over 1 full minute. Normal is 60 to 100. We're going to use our fingertips, not the flat area of our fingers. We don't use our thumb to take a pulse. And the pulse is going to be located at the thumb side of the wrist at the bendy part, way up here. We're going to say start and stop while we're counting, so the evaluators count with us. In Florida, we're going to count with 2 evaluators, and this requires documentation. With dressing a resident, we're going to ask about the clothing preference. We'll get clothing before we undress. We'll lift from below and support all joints while lifting. We're going to undress the strong arm first and dress the weak arm first. We don't want to overextend or force movement. We're going to adjust the clothing for neatness and appearance. We're going to dispose of all soiled items in the hamper, and the call light will be placed in the stronger hand. Hand and nail care. We're only going to wash what the care plan tells us to. We're going to support the wrist and arm at all times. We'll soak the hand in water. Whatever we wash, we rinse. Whatever we rinse, we dry. Make sure the hand is on a towel when you put it on the table. We'll use the slanted end of the orange stick to clean under the nails and wipe it off in between. We're going to file with an emery board in one direction toward the center, and we apply lotion last. When we apply the lotion, we warm it up and we wipe it off. Making an occupied bed. We remember that by clean rolls toward you, dirty rolls away. We're going to make sure the patient is on their side in the middle of the bed when changing the bottom sheet. You don't want them on their back. When they're on their back, they take up a significant part of the bed. If you turn them on their side, they take up less. So it's easier to change that bottom sheet. But you always want them in the middle of the bed. So to do that, we're going to have them scoot toward us and then roll to the center. That way they're taking up the least amount of space, but they're safely in the middle. Okay. Clean rolls toward me, dirty rolls away, remain behind, the patient's behind. Will smooth all wrinkles, make hospital corners, loosen sheet over the toes, and replace the pillowcase with the opening facing away from the door. We didn't talk about that too much, but remember a lot of people walking up and down that hallway in a clinical facility. Patients, staff, visitors, everybody. They're all breathing. We don't want pathogens on air currents to come in and be able to get into that pillowcase. Remember, under that pillowcase is warm, dark, and moist because we drool. So you don't want any pathogens between the pillow and the case. So if we have the opening of the pillowcase facing away from the door, it reduces pathogens. This was a very old principle left over from the days of TB, tuberculosis. So this was a very important principle when we had a lot of patients with tuberculosis. Not as important now because we kind of have tuberculosis kind of under control, although periodically it does kind of flare up occasionally. If we have a tuberculosis patient on the unit, this goes into effect. Pillowcases always face away from the door. Okay, good. All right. Range of motion. Remember that CNAs do exercises to retain function. We'll lift extremities from below with a flat palm. We always provide 2 points of support near the joints. We're going to move slowly and smoothly and return all the way to the start position. Thank you, guys. Flexion extension is up, down. Abduction, adduction is side to side, and rotation is around. So look at how much you've learned. We are now half done with the class. Today is a halfway point. Crazy. Goes fast. Goes fast. So let's go to page 138 to jump into today's skills. All right, so when you're looking at page 138, you'll see all the principles along the side there. You'll see them all spelled out here. The skill-specific principles are going to be here. We'll go over those in a minute. We have our Cliff Notes version. We have a video, and down here is test-specific information. So test-specific information for this skill, it says someone with your level of experience should be able to complete this within 8 minutes or less. This is going to be done on another testing student, so you guys might be the patient for this. That person will be in bed, and charting is not required. So we already know skill rules, opening, glove rules, barrier rules, privacy blanket, linen rules, and the closing. So we learned part of scoot and roll last class. Let's finish that up now. If you look on page 139, at the top of the page is our care plan. It tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Down at the bottom of the page, you've got your supplies, and then in the middle, you have step-by-step instructions that tell you exactly how to get this done. We talked about this on Monday. Please remember that side rails are a restraint. We cannot use side rails. So even though we're turning a patient onto their side, we can't use side rails to keep them safe. So after the turn, they need to be in the middle of the bed. You can't just walk up and turn somebody so they're on the edge. That is the most common way that this skill is failed, is the CNA doesn't ensure the patient is in the middle of the bed after the turn. So in order to do that, we're going to scoot the patient toward us and then turn them so that they're in the middle after the turn. Remember that positioning rails or half rails are not side rails. They don't interfere with the patient's ability to get out of bed. So they're not a restraint. A full rail is a restraint. Let's talk about immobile patients for just a few minutes. Immobile patients can't move on their own. So if somebody is immobile, that means they can't do anything for themselves. We're going to do it all. We're going to feed them. We're going to change them. We're going to clean them. We do it all. Immobile patient means they cannot move on their own, which means they can't do anything on their own. But there's a couple of special rules that go along with somebody caring for somebody who's immobile. One of those rules has to do with skin integrity. Now, we need to understand that when somebody is immobile, every body system we just talked about is going to be affected. Every single one of them. If this lady can't get out of bed, every body system is affected. Our digestive system is going to be affected because when we eat, our intestines are smooth muscle. They're muscle, but they're smooth. They don't move on their own. Your intestines require your abdominal muscles when you're walking, sitting, talking, eating, breathing even. Those muscles contract and expand, and that's how food moves through your intestines, is through the action of your abdominal muscles. So if we have somebody laying here that isn't moving on their own, stuff isn't going to move through their intestines very well. That's going to make them more susceptible to constipation. Okay, make sense? If we're laying down, our lungs are not going to fill as well. And that's just because of gravity. Gravity is going to pull secretions down. That's going to keep fluid in the bottom of the lungs, the part that's down, and that's going to keep our lungs from inflating very well. It's going to affect your mental status when you're immobile. You're going to have decreased concentration. You're not going to be as sharp. So every single body system is affected, including your muscles, skin, and bones. So one of the things that we want to look at when we have immobility is the effect on the skin. So let me show you this real quick. I need you guys to play along for a second. I want you to take one hand and put it underneath your leg and sit on it for the next 2 minutes. Now, you're going to want to pull it out. It's going to get uncomfortable, but please play along with me because I want to show you something here real quick. And I'm only going to do this for 2 minutes, and then I'll ask you to pull your hand out and we'll take a look. So when we are laying down, we have lots of points on our body that are in contact with the bed. Okay, lots of points that are in contact with the bed. We call these pressure points. So the back of the head, the shoulders, the elbows, the lower back or coccyx area, the backs of the thighs, the backs of the calves, and your heels. All of those areas are areas of increased pressure. It's where the bone is actually pressing down on the muscle into a surface. So what happens when that happens? So this is a graphic that shows we have a bone pressing down into the muscle. That's going to compress the fat. That's going to compress the skin. And all of these blood vessels that are in the skin are going to get crimped, closed. Now, what do you think is going to happen to tissue if it's not getting good blood flow? What? Yeah, it breaks down. It dies. Absolutely. And that's what happens here. Because we have this increased pressure pushing down, pushing down, pushing down, it's just like if I take this straw and crimp it closed. No, nothing's going to get through it. It's closed. It's shut. That means that anything out here isn't going to get good blood flow. And any tissue without blood tends to die. You can see that here. All of these blood vessels are going to get crimped shut, and that interrupts the blood flow, and it's all because the bones are pressing into the muscle, which presses into the fat, which presses into the skin. It doesn't take long for this to happen. Pull your hand out for a second. Take a look at it. Did you see color changes? Anybody get red? Look really close. Do you see the pattern of the chair or your clothing on your hand? Anybody see that? That was 2 minutes. That's all that took, 2 minutes. Imagine if we left your hand there for 24 hours. Now, if 2 minutes got you lines, 24 hours, those lines get deeper and deeper and deeper and deeper and deeper and eventually cut into the skin. This is how pressure sores form. So when we have somebody who cannot move themselves, we have to move them on a very specific schedule to relieve that pressure and to restore blood flow to those tissues so that they don't break down. Does that make sense? All right. So when you pull your hand out, you probably saw some redness or some patterns. You'll see this on patients as well. And this is why we really want to reduce the wrinkles. Remember when we made the occupied bed and I told you we have to reduce the wrinkles? That's because it's going to be an area of increased pressure. So here you guys actually saw the pattern of the chair or your clothing. In a clinical setting, you'll actually see the pattern of the wrinkles in the skin. So reducing wrinkles will help. Now, this happened in just 2 minutes. Imagine if we left you a whole lot longer. So this is why we're going to change position frequently when our patient is immobile. And we're going to use a turning clock. So every 2 hours, when a patient is immobile, they're going to have to be turned. And that's around the clock. So we're waking them up at 2 a.m. and changing their position. We're waking them up at 4 a.m. and changing their position. 6 a.m., 8 a.m., 10 a.m., all the way around the clock. So they're not going to sleep all night. Now, some very well-meaning CNAs might think to themselves, oh, I really don't want to wake her up. I mean, she's sleeping so nicely. I'm just going to let her sleep. Well, if you do that and you don't change, her skin does not care about her sleep status. Her skin, because of that pressure, is going to break down. And when you finally do turn her, she's going to have a bed sore that's probably going to take us 6 months to a year to fix. And they're insanely painful. Insanely. The worst place this happens, guys, is in the hospital. I don't know why. Nursing homes do a great job at turning their patients. They do a great job. If you have an immobile patient, that patient gets turned. We prevent bed sores. Nursing homes usually do a great job. You send that patient to the hospital for something else, that hospital doesn't turn them. And then the patient comes back with a bed sore on top of whatever they were sent out for. And it takes us months and months and months to fix it. So if you go to work at a hospital, please make sure that you're turning the patients. So this is called a turning clock. We use this when we are working in healthcare. If you don't have one, you can make one. But it tells you, if I walk into the patient's room at 1 a.m., they should be on their left side. If I walk into the patient's room at, let's say, 5 a.m., they should be on their right side. If I walk into the patient's room at 2 p.m., I should be turning them onto their right side. So this clock tells you where the patient should be and where you're turning them to. So when you're looking at this clock, you'll see it says right side back, left side back, right side back, left side back. So right back, left back, right back, left back. You don't ever want to turn an immobile patient on their stomach unless the care plan specifically tells you to. And that's because if a patient is immobile, most of the time they won't have the muscle or the nerve innervation to lift themselves off of their chest cavity for their lungs to inflate. You can suffocate a patient that's immobile by putting them on their stomach. Anybody here with new baby? They probably told you don't put new baby on there. Yeah. And that's why. I know. Yeah. Thankfully. All right. So we always want to make sure our patient is in the safe zone or the middle of the bed. And we always turn them away from us. So we remain behind, the patient's behind. Especially once they've been turned on their side. You don't want them on the edge of the bed. So, yeah.
Does the nursing home have any special beds have those turning motion beds that they can turn patients.
Some do, but even still, that doesn't really take the place of good old-fashioned
And
turning.
that's basically the reason why in the hospital they don't turn them as often is because they
Right, they rely
stick in
on,
the hospital. So
yeah, they rely on the air motion beds, but it's still, you're diffusing the pressure, but you're not really eliminating the pressure. So even still, there's no substitute for turning,
right.
even on a alternating pressure mattress. So in order to make this happen, we'll ask our patient to scoot toward us, and then we'll turn them away from us so they're in the middle of the bed. Now, if they can't scoot toward us for whatever reason, they just physically are unable to, we can use a draw sheet to move them toward us. A draw sheet is nothing more than a sling that's on the bed. And I'll show you how this works. Okay. So we've got this patient in bed. And underneath the patient right here is a top sheet, just like this, but it's folded in half lengthwise, long ways. And I've got it underneath the patient so that the top edge, the folded edge, is between her shoulders, right around her shoulders. And the bottom edge, or the two halves that are folded together, is under her legs. Now, I can use this as a sling. If I go over to the other side and untuck that as well, I can take this, roll it up, roll it up. And then once I have it rolled like a handle, I get a wide base of support. I lift up and scoot the patient toward me. So you can use it as a sling. If it's a really heavy patient or you're trying to move them up, get another person on the other side. You both lift and it becomes a sling. You can move the patient up or closer to you. That's how a draw sheet works. It stays on the bed underneath the patient and it's used as a sling. So you can see that here. You see the folded edge will be around their shoulders. The two halves that are folded together is going to be at the bottom under their legs, and you use it as a sling. You can also move somebody in segments. So head, shoulders, torso, hips, legs. You can move somebody in segments. If I don't have a draw sheet, segments is what I use. Before we turn an immobile patient, somebody who cannot move on their own, we position them to make that turn a little bit easier. And the way that we do this is, remember, we remain behind the patient's behind. So we always turn them away from us, right? So we're going to stand on the side of the bed opposite the way we're going to turn them. We're going to have them scoot toward us. So if I'm going to turn her on her left, I'm going to be on the right side of the bed. Scoot her toward me, either asking her to scoot, using a draw sheet, using the segment method. However, I've got her on the edge of the bed, closer to me. And then I'm going to take her furthest arm and go up. Closest arm goes over, so she looks like this. If I were standing on the other side of the bed and turning her onto her right side, she would look like this. Okay, furthest arm up, closest arm over. Good. Closest knee is going to be bent with a foot flat on the bed. The furthest knee is angled out. So you're not going to do this on the mannequin for the test. This is on a real person. And that's because the mannequin doesn't bend this way. Let me show you. If I try to put the mannequin's arm up like this, it doesn't really lay like a normal person's arm would. If I try to take this arm and cross her chest with it, it doesn't. So you can't really do this on the mannequin. When you're practicing this, you need to practice it on a real human. Okay? Because mannequins don't move the same way a real human does. So furthest arm up, closest arm over, closest knee bent, furthest knee angled. When you do that, when you get them set up like that, it is super easy to put a hand on the shoulder and one on the hip and just roll them on their side. They don't have to help. I can turn somebody 3 times my body weight with no stress at all on them or me. It's all about proper positioning first. And then we're going to use some pillows to keep them in that position. We're going to put a pillow behind their back in a roll. We're going to put a pillow between their legs, specifically between the knees and the ankles. We'll put a pillow under that top arm to keep it in a neutral position. And then we'll adjust the pillow under their head to make sure it's under the head and neck and not the shoulder. Call light should go in the bottom hand. We don't want the call light cord over their neck. So call light goes in the bottom hand. Okay, good. Questions? All right, so let's look at the care plan one more time. Position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. Now, this is the care plan from the state exam. It says they're unable to assist with turning. It does not say they're immobile. So you can ask the patient for the test to scoot towards you. Okay, good. All right, let me show you this one.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? Questions? All right, let's get into foot care. There's a lot I have to tell you about foot care. The skill itself is very much like hand and nail care. We remember with hand and nail care, well, I'll get there. I've got a slide for it. I get ahead of myself. All right, when you're looking at this page 118 for foot care, you can see all the principles down the side. We know everything that we need to know to do this skill. We know to follow the care plan. We know how to do the opening. We are going to wear gloves for this because our answer to all of our questions is maybe. We can't tell what's on the bottom of the foot until we're there. So because there might be a skin opening, there's a maybe, we're going to wear gloves. Plus feet, you know. We're going to use a barrier, but this time our barrier is going to be on the floor where the feet are. We know about linen rules. We know whatever we wash, we rinse, whatever we rinse, we dry. We know how to clean the basin, and we know how to do the closing. There's nothing new to learn here. We have a video on it. Test-specific information. Somebody with your level of experience should be able to do this in 13 minutes or less on a live patient sitting in a chair at the side of the bed. No new principles to learn. If you look on page 119 at the top of the page, you'll see the care plan. Care plan says provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. Let me explain to you that last sentence there. You are going to be doing this on a live person. Now, in a normal situation, after you do foot care, you'd probably put new socks on the patient, clean socks on. Well, remember, this is going to be done on another testing student like you. You might be the patient for this. You probably don't have a pair of clean socks in your pocket. So because of that, the care plan is going to say, replace their sock and shoe at the end of the skill. Because before they had that, people would just leave the foot bare and just be done. So it's telling you, put their sock and shoe back on. Don't ignore it. Don't leave the patient with 1 shoe and sock and 1 bare foot. That's weird. Can you imagine trying to walk like that? That would be weird. So your care plan, in this case, we're definitely going to follow it. But it's very specific to the test. Okay. Replace their sock and shoe at the end of the skill. A lot of supplies necessary for this. You've got to learn your supplies. I will give you a little, how do I put this? Cheat for the test. When you're thinking about supplies, specifically washcloths, if you're washing a small body part like 1 hand or 1 foot, you need 2 washcloths. 1 to wash, 1 to rinse. Everything else for the test takes 4. So hand and nail care and foot care, 2 washcloths. Everything else takes 4. So when you're getting supplies, that might make it a little easier for you to remember. So hand and nail care and foot care are very, very similar. We're going to support everything while we move it. We're going to soak it in water. We're going to wash, rinse, and dry. We're going to make sure that the hand or foot is on a towel while we're doing that. Where this changes a little bit is after that. So remember with nail care, we had to clean under the nails with that orange stick. We don't do that with toes. We don't do anything with toenails. Nothing. We don't clean them. We don't file them. We don't do anything with toenails. Bless you. Nothing except look at them. Because every facility has a podiatrist that comes in, and the podiatrist will do whatever is necessary with toenails. CNAs don't. Podiatrists do. But the podiatrist doesn't go room to room looking for victims. Do you need me? Do you need me? They don't do that. They walk in, there's a list, they see the people on the list, and then they leave. So how does the patient get on the list? Well, you do foot care, you notice there's a problem, you tell the nurse puts them on the list. So if we aren't doing foot care, the patient's issues will never get addressed. So we don't do anything with toenails other than look at them. We don't put lotion between the toes. That holds in moisture. We get warm, dark, moist, and then fungal infections set in. Ew. We're going to inspect all surfaces for wounds, sores, rashes, or red areas. Never let a barefoot touch a floor. So it's always got to be on that barrier, preferably on the towel on the barrier. And we'll replace the sock and remove wrinkles before we put the shoe back on. So this is actually, to me, a little bit easier than hand and nail care. You're simply washing, rinsing, drying, and lotioning, but your whole point here is to look. You have to know why you're there. So this is a little bit easier other than the fact that you've got to get on the floor to do it. But in order to understand why this is such a big skill, we have to talk a little bit about diabetes, okay? So this is a 5th grade version of diabetes. I'm talking super simplified. There are people that spend years and years and years and years studying diabetes. This is not that, okay? This is a very overly simplistic version. But it's important that you know this because most of your patients are going to have some form of diabetes. So we need to be aware of this. So in your body, your cells need fuel, right? So just like your car, you need to fuel your cells. And that's one of the reasons we eat. The other reason we eat is for body heat, but your cells need to eat. The main food source for your cells is sugar. It's what your cells like to eat. Now, we eat carbs, and those carbs break down into sugar, and that sugar fuels the cells. And this is a great system. It works great. And lucky for us, carbs are good. They taste yummy. So what are some examples of carbs?
Bread.
Potatoes, bread. What's that? Rice, pasta, sugar, anything that's made with sugar, flour, anything that's made with flours. We call it the rule of white. If it's white, it's probably a carb. Now, a notable exception to this, obviously, is cauliflower. But pretty much if it's white, it's probably a carb. Good? Make sense? Okay. And that's not a bad thing because your cells need that sugar to run. Where we get into trouble is carbs in our society, they get a bad rap. Man, everybody talks about carbs, stay away from carbs, cut your carbs. Carbs are not bad. Carbs are necessary. What's bad is carbs in excess. And in America, we do everything in excess, including carb intake. So what happens is when we take in too many carbs, your body has to do something with it. Now, we can't excrete carbs. It's not like vitamins. You take a multivitamin, whatever you don't use, you pee right out. It's gone. No worries. But carbs aren't like that. We can't pee them out. We can't sweat them out. We can't get rid of them in any way. once we take them in, we're stuck with them unless they're being used by the cells. Now, as long as we're in balance, as long as the carbs you're taking in are being used, you're in good shape. But if you're taking in more carbs than your body can actually use, we can't get rid of them, so they're going to circulate. Now, they'll circulate for a little while until the body says, okay, you clearly aren't being used. Let's pack you away for later, because there may come a time when we need some carbs and we don't have any in the bloodstream. So they put it in little boxes called glycogen, and they shove it in a storage unit called a fat cell. That's why your fat cells exist. Your fat cells are storage units for excess glycogen. So we just pack it away. And as long as you continue to eat carbs, your body has no need for that stuff in storage, so it just sits there. Now, over time, that glycogen gets less and less fresh. So eventually, the body's like, I don't want to use that stuff. Do you know how old that's been in there? I mean, that can of beans has been in there for 40 years now. I don't need that glycogen. So it's really hard. This is why as you age, it's really hard to get rid of fat that's already there, because your body just doesn't want to burn it. It's not an efficient fuel anymore. Make sense? Good? Okay. So your body will pack away whatever glycogen or glucose or carbs it did not use. Eventually, when all the storage units are full, blood sugar will build up in the bloodstream because there's nowhere else for it to go. Okay, so let's explain how this works. So everybody understand this? You eat carbs, breaks down into sugar, sugar enters the cells, and everybody's happy. All right. The one part of this I didn't tell you is that sugar can't enter the cells on its own. Those cells are actually locked, and sugar needs a key to open the cells. That key is actually produced in your body, actually in your pancreas, and that key is called insulin. Insulin is a hormone, and it opens the cell so that the sugar can go in. Okay, good, good. So if you eat sugar and you don't have insulin, that has no way of getting into the cell. So a healthy system, cell is starving. Your body says, I'm hungry. You go eat some carbs. The body makes insulin. Insulin opens the door. The sugar enters the cell. The cell is now happy and life can go on. This is a good, healthy system that works as it should. When we have diabetes, your cell is starving. Your body says, I'm hungry. You eat some carbs, breaks down into sugar, but there's nothing to open that door. So the cell is still starving. It yells at the brain, I'm starving. Brain says, oh, we must need some food. Triggers a craving. You go eat some more. We get more sugar into the bloodstream, but it still can't get into the cell. Cell is still starving. Your body says, I need carbs. So you eat more carbs. So all we end up with is a whole bunch of sugar in the bloodstream outside of the cell. It can't get in. This is diabetes. High blood sugar. The blood sugar is high because that sugar can't get into the cell. It can't get into the cell because the pancreas is not producing insulin. You guys see how that works? So let's talk about what that does to the body. Here on planet Earth, we have gravity. Gravity controls a lot of different things. Now, this is the artery system of your body. This is what takes blood to the tissues. And when we think about blood sugar inside this artery system, okay, blood sugar is inside, because remember, it's not in the cells. We have to think about what that looks like. So, sugar is a crystal. Have you ever seen a cake or a cupcake left on out on a counter for a couple days? It has frosting. That frosting kind of separates, gets a little crystally and oily, right? Well, that's sugar. This is sugar. These are crystals. This is what's inside your blood vessels. Do you see how jagged that is? Right? So the sugar that is circulating inside your artery system looks like this. It's all sharp and jagged. And it's just like the frosting on that cake or cupcake. It gets a little heavy with these crystals. So those crystals start to just settle wherever they are. And it coats the inside of these arteries. Now, when it does that, it makes them super stiff. So they can't expand or contract. But even worse, this jagged mess of stuff on the inside of the arteries is going to catch anything floating by. So that's going to make our arteries a big goopy mess. Let me show you what I mean. This is a brand new artery. This is a nice artery. I wish that mine looked like this. It doesn't. This is a nice artery. This is what we're born with. They should all look like this, but they don't. Because over time, with our eating habits, we end up with a little bit of buildup. Do you see how much narrower this is than this? It's just a little bit, but there is narrowing there. You guys see that? Little tiny bit of buildup here, nothing really to worry about. But this person probably has a little bit higher blood pressure because it's narrower, which means that the pressure inside is greater. Smaller hose. Good? Now, if we ignore this, if we don't do anything about this, when our blood pressure starts to go up a little bit, we ignore it, then we end up with something like this. Now, the reason that it gets all goopy like this is because these crystals that have settled on the inside of this artery is going to catch everything floating by, like cholesterol, which looks like pizza cheese in your arteries. It legitimately looks like pizza cheese. So all that pizza cheese is going to get caught up in this crystal stuff. It's also going to shred cells and platelets as they go by. So you end up with this big goopy mess. How much blood do you think is getting through there? Not much, not much. So our diabetic patients are probably a little tired. They don't want to get up and walk. Okay, good. Now, if we ignore this, we end up with this. Do you remember on Monday I told you anytime blood slows down or stops, it clots? Do you guys remember that? Do you see that blood clot there? It's exactly what happened. This blood slowed down and stopped, so it clotted. This is how heart attacks happen. It is a closing off of an artery to the heart. It's how strokes happen. It's closing off of an artery to the brain. This is bad. Make sense? Diabetes, bad. So, remember that these sharp crystals, right? Sharp crystals are inside these arteries, and we have gravity on planet Earth. So gravity is pulling those sharp, heavy crystals down. What's the lowest point of the body? The feet. So because of gravity, we're going to have more of these crystals in our feet, in the blood vessels of our feet. Have you ever heard a diabetic person say that their feet, they have neuropathy or their feet hurt? It's because they don't have good blood flow because of the crystals. Now, those crystals, heavy crystals, also settle in the small blood vessels of the hands. This is called peripheral neuropathy, and this is why we do hand and nail care and why we do foot care. Is because if our diabetic patients have uncontrolled blood sugar, they're going to have effects in their feet and their hands. Good? Make sense? But those effects aren't just limited to the arteries. They also coat the nerves. So just like in up north in the winter, you can get ice on electrical lines, and that causes a brownout or even a power outage because that ice is coating the electrical lines and the electricity can't get through. Same thing happens in the nervous system. As all of those nerves get coated in this sugar, these crystals, it can't relay messages. So let me give you a scenario here. This is a real life story, really happened. I was a agency nurse. Agency nurses are substitute nurses. I don't work for the facility. I get sent in as a substitute. So I go in this one day and get report. I'm doing my rounds, giving medications. I walk into a patient's room and I flip on the light and he starts yelling right away, turn it off, turn it off, turn the light off. I had one of those really small lights right above the bed. So I asked him as I walked to the in the room, I said, is there a reason we don't want the lights on today? Do you have a headache or something? He says, no, I've got diabetic retinopathy. The bright light really hurts my eyes. Okay. So while I'm standing there, I'm doing a head to toe assessment and I'm catching an odor. If you've ever smelled a wound, they're very distinctive. So I knew that I had a wound somewhere. I could smell it. So I pull out my report sheet. I look, there's nothing about a wound. There's no wound care orders. There's no nothing. So this is a problem. So I asked him, can you turn over so I can take a look at all of those pressure points that we saw on the slide earlier? The back of the head, the shoulders, the lower back or coccyx area, the back of the legs, the back of the calves. I get down to his feet and I say, can I take your slipper socks off? And he says, no. Okay, well, there's my red flag. Because if he told me no, what did he tell the CNAs? And nobody reported it. So we have no idea how long this guy had gone with nobody looking at his feet. No idea. But the problem with diabetes is when you have this corrosion of the nerves, anything that's happening to the feet doesn't get up to the brain. So if the guy's got a foot problem, the brain isn't aware of it because the message can't travel through that line. So I sweet talked him because you can always get further with patients by being nice than being mean. So I turned up the charm and he had that slipper sock that was stuck to the bottom of his foot. So I knew I now know where the problem is. I go get a basin of salt water. We call it normal saline, put the whole foot in, sock and all. Go take care of somebody else, come back 10, 15 minutes later. I went to take the sock off. And as I did, I kind of had to give a little pull to separate it so I could see what I'm working with there. And as I did, this goes flying past my head. This is one of those white metal painted thumbtacks. Wasn't this exact one. This is one like it. But he had those little slipper socks on. And because he had the slipper socks on, this, yeah, well, it was able to get through and nobody really saw it because it looked like the dots on the bottom of the slipper sock. And remember, he kept his light very dim in the room. So we have no idea how long this had been there. But unfortunately, when I got the sock off and was able to take a look, he had an area about this big around on the bottom of his foot that was hard, black, dead tissue. So, yeah, well, everything grew. It caused a wound that wasn't healing, and the tissue around it died. So we're good in healthcare. We can heal a lot of things, but dead is dead. We can't heal that. So I knew this guy's got a really bad road in front of him. This is a bad, bad thing. So I called the doctor, called the wound care specialist, called the family, wrote up my notes, took my pictures, and left. Not my facility, not my patient, but he stayed on my mind because he was young. He was only in his early 50s, and he was there from complications of a stroke. He was on the rehab side. And I was really hoping that this guy would be able to get treatment enough to be able to go home. He's young. And it was months and months later, not quite a year, I don't think, but months and months later, I get back to that facility, get assigned, and now I'm on the long-term care side, and I look, and sure enough, there's his name on my list of patients. So I went in the room and I said, Hey, I'm Patty. I'm the nurse that found the wound on your foot. How are you doing? He pulled the sheet aside and he had to have a below the knee amputation. So here he is in his 50s and he's already lost a leg. Now, to me, this was very tragic for a couple of reasons. Number one, it was completely preventable. If he had shoes on, where would that thumbtack be? Yeah, we don't amputate shoes. He would have gotten to keep his leg. So when it comes to walking patients, if their feet hit the floor, we better be talking about shoes. You got to make sure they have shoes on. Slipper socks are not enough. And in healthcare, we have things that are way more dangerous than a thumbtack. Sharp objects that can absolutely penetrate. If you wouldn't let a child walk on a floor barefoot, you should not be letting an adult walk on a floor barefoot. Slipper socks are not enough. They don't protect against injury. And they honestly don't do a great job about protecting against slips either. So walking requires shoes. Does that make sense? If this guy had just had shoes on, this would never have happened. But there was another reason this was preventable too. Because if the CNAs had told the nurse, hey, he won't let me do foot care, the CNA could have, or the nurse could have addressed this and figured out what the problem was. And if we found it early enough, before that tissue died, go ahead, you're good. Before that tissue died, then we could have maybe fixed it before they had to take his leg. Now, the reason that he didn't know there was a thumbtack in the bottom of his foot is because of this. Because those nerves get coated with that sugary substance and signals can't get up to the brain. So the foot knew the thumbtack was there. It's saying, hey, brain, we got a problem down here. But the signal never made it to the brain. So the brain was not aware. A lot of people with neuropathy don't feel pain from injuries.
Was he still able to walk around?
He was in long-term care. He had to sell his house and move into a nursing home. That's very sad. It's horrible. Horrible. This should not be allowed. We can do better than this, especially since it was preventable. Okay. So that's why we're doing foot care, is because your patient might have an injury that they don't know anything about. They don't even know it's there. So it's up to us to find it. If you go in to do foot care and your patient says no, who should you tell? The nurse. If somebody had just reported this, it probably would have gone a whole different way. Yeah, Rebecca, I'm sure. Yeah, I agree. Oh, sad story about the gentleman with the foot wound. Very tragic. I agree. I hope you're feeling better. Okay, so that brings us to shoe rules. If the patient's feet hit the floor, we talk about their shoes. Everybody that's walking needs to have shoes on. And this is another reason why our care plan for this skill tells us to replace the shoe and sock at the end of the skill. Slipper socks are not enough. We'll go over the rest of this in a future lesson. All right. So if your patient doesn't have shoes, or if they refuse to wear shoes, who should we tell? The nurse. At the very least, put a second set of slipper socks on. And let me explain why. This is an infection control issue. So let's say that I had my gallbladder out this morning. I went to a same-day surgery center, was supposed to go home at the end of the day after the surgery. So I go in, I get my surgery, I get done with the surgery, but my blood pressure is a little bit high. They don't want to send me home. So they put me in the hospital overnight for observation, and they give me that bed over there because it's the only one available. This is my roommate. She had a hip replacement surgery done 3 days ago and developed an infection in her surgical site. So she's on IV antibiotics, and they're big antibiotics, and they cause diarrhea. So this poor lady has gone through the ringer. Now, she's kind of stuck in bed because she just had a hip replacement. She's up on a walker, but it takes her forever to get to the bathroom with assistance because she just had a hip replacement. She's not very fast, and she's got diarrhea. So as she's trying to make it to the bathroom, she's not going to make it to the bathroom and she's going to leave a trail behind her. Okay. CNA cleans it up. I'm in that bed over there. And at some point during my stay, I'm going to have to go pee. So I'm going to get out of bed and I'm going to walk in my slipper socks to that bathroom. I'm going to do what needs to be done. And I'm going to come back and walk to the bed in those slipper socks. When I get into bed, my slipper socks get into bed with me. What just crawled into bed with me? All of those pathogens from diarrhea. Absolutely. Absolutely. Now, remember, I had a surgery as well. I had my gallbladder out. I've got 4 little incisions. And incisions are warm, dark, moist places. And because they're little, they're just covered by a Band-Aid. They don't even have proper sutures. Warm, dark, moist. So those pathogens that just crawled into bed with me are going to get into that incision and I will develop a surgical site infection. Should I be walking on that floor without shoes? No. If I don't have shoes available for whatever reason, you should tell the nurse. We can call the facility, we can call the family, we can call anybody and say, hey, we need shoes. If the patient's homeless and has no shoes, we have a social worker we can call and say, hey, the patient needs shoes. We got resources. We just need to know there's a problem for us to solve. Make sense? Good? Good. So if your patient doesn't have shoes, you need to let the nurse know. If they refuse to wear shoes, you need to let the nurse know. But if they're walking around in those slipper socks, at the very least, put a second set of slipper socks on that you can remove before they get into bed for infection control purposes. Okay? Good? Remember, slipper socks are not enough to protect from injury or pathogens. All right, so our steps here, we're going to soak the foot in the basin on the barrier, support the foot while moving, wash, rinse, and dry everywhere. But when we put lotion on, we don't put it between the toes. We'll inspect all surfaces. That's why we're there. This is the whole reason we're there. It's not about getting the foot clean. They don't care about you getting the foot clean. It's about looking at the foot. So during the skill, you have to say something like, I'm looking at the foot. No bare feet on the floor. Replace the sock, removing wrinkles. Remember, wrinkles are bad. And apply and secure the shoe over the sock. Okay? Step-by-step instructions are here. I'm going to show you the video for this, and then we're going to take our break. Oh, no, Tanya, I'm so sorry to hear that. Yeah, come on in anytime. That's fine. We're getting ready to go on break, but if you want to stay home, just join through the live stream. That's fine. I'm so sorry to hear that. All right, and good morning, Miss Patty. I took my test yesterday, took my test. I passed both. Thanks to you for being a great teacher. Congratulations. Congratulations. Okay. Okay, after this, we will take a break.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. I'm going to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands and apply lotion to all surfaces except between the toes. So I'm going to lift your foot and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There you go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps in my skill, make any corrections, and tell the evaluator my skill is done.
All right, any questions on that?
No questions? Okay, let's go ahead and take our break.
no worries. Okay, no worries. I hope everything goes well. Thank you. You're hired.
right. Let's go ahead and get started. Okay, so on page 92 of your skills book, you'll see information on mouth care. There really honestly isn't much for me to teach you on mouth care. You guys all know how to brush teeth. Okay, there's nothing earth shaking here. So you know all the principles involved. Wet the toothbrush before you put toothpaste on. That helps it distribute a little bit better. Make sure the patient is sitting up. Cover their clothing with a towel. Make sure that they rinse and spit as often as they need to. Only use a little bit of toothpaste for this. If you use a lot of toothpaste, they're going to have to rinse and spit a lot. Remember, they're not over a sink. So the more toothpaste you use, the harder it is for them to get that toothpaste out. So a little bit of toothpaste is all you really need. We know all of the rules involved here. Somebody with your level of experience should be able to brush this person's teeth in 12 minutes or less. It doesn't take 12 minutes to brush teeth. They're giving you all the time you need. Don't rush this. It's not a hard skill. A lot of people find it a little icky, because you're brushing somebody's teeth, but it's not a hard skill to do. The one thing that I will tell you, though, is if your patient can brush their own teeth, they're going to. Patients don't want you in their mouth if you don't need to be there. Does that make sense? So how do we know which patients are going to require us to brush their teeth? The care plan. So we're not going to brush everybody's teeth. If somebody can brush their own, they will. Now, we may have to help squeeze toothpaste out, right? Because remember arthritis, we talked about arthritis, and arthritis can impact your ability to squeeze. So maybe we might have to help them with that. We might have to help them to the bathroom. I mean, we can help with certain aspects of this without actually having to do the whole mouth care part. But in general, people find it a little icky to have people in their mouth if they don't need them there. Okay, does that make sense? All right, so nothing new to learn here. Your step-by-step instructions are on page 93. You've got your supplies at the bottom. And usually at about this point, somebody asks me, well, what if they have dentures? Denture care is going to be a whole nother skill that we're going to learn next week. So this is just mouth care, learning to brush teeth when there's teeth. Okay, we'll learn about dentures later. So safety first, this is an important checkpoint. We want to make sure the patient is sitting fully upright. This is not a safe position to brush teeth, and this is how your patient will be positioned at the beginning of the skill. The evaluator is going to have them in bed, head of the bed down. So they want to see, are you going to recognize that that's a safety issue and put the head of the bed up? Now, when I say up, I mean all the way up. This is not one of those things where you ask the patient, are you comfortable? You don't want to put the head of the bed up just a little bit. Like you don't want to do something like this. Is that comfortable? Okay. No, this is not safe. When we put a head of a bed up for mouth care, we keep pressing that button until it stops moving. We keep going and 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 keep going. Okay, when the bed stops moving, that's the full upright sitting position. Good? Your arm needs some help here. Hold on. There we go. Good? Now, if you notice, when you have a pillow behind the head, when you're laying down, it's comfortable. But when you're sitting up, that pillow actually pushes the head forward a little bit. This is not safe. So when you're going to do mouth care on somebody that's sitting up, you need to get the pillow either down behind their back or completely out from behind them. but don't just leave it behind their head because it actually pushes their head forward just a little bit. So if we know that we have to put our head of the bed up, and we know that the bed controllers probably aren't clean, we have to figure out when we should do that. Now, the problem is that I can't touch the patient until my hands are clean. I have to put the pillow down behind their back, which means I have to touch the patient. So this can get really confusing for students. Wait a minute, when do we do which step? So I've got it all detailed out for you in the step-by-step instructions. If you follow this, you're good. Okay. So we're going to do our opening. We're going to wash our hands. We're going to use a paper towel to put the bed in a full upright sitting position and then adjust that pillow. Okay, good. So your step-by-step instructions are going to tell you how to do that. Now I am going to show you the video for this one, and the video is wrong. The video is how we used to do it. So back about 4 years ago, they changed it. I haven't redone the videos yet. So in the video, you're going to see me put the head of the bed up before I wash my hands, because that's how we used to do it. But now we can't touch the patient until our hands are clean. So we had to redo the steps. So your book is right. The video, remember that we're going to put the head of the bed up after we wash our hands with a paper towel. All right. We're going to use a towel over their chest to protect their clothing from toothpaste. We'll wet the toothbrush before we apply toothpaste, and we brush everything they have. Top, bottom, front, back, tongue. There's no time requirement here. You don't have to brush for 2 minutes or anything like that. Just get it all done. We're going to rinse. Remember, if you use a lot of toothpaste, you're going to be there a while rinsing, and make sure that their face is dry at the end. This is actually the most forgotten step on this skill. People forget to dry the patient's face because you're all up in your head, right? So don't forget to look at the patient. That's kind of important. If their mouth is drippy wet, they probably aren't comfortable. Okay. So good? Good. All right, let me show you this one. This is a very easy skill. If I had to get a skill, it's probably one I would want to get. Just because we all know. We all know how to do it.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. Remember, we do that after hand wash. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. Any questions on mouth care?
So we don't actually wash our hands before we give them the remote or anything? After the gloves off, we can go give them the remote and everything
Right.
first? Okay.
So here's the thought process there. And you have to understand that no matter what, there's always a point where clean crosses to dirty and dirty crosses to clean, because it's just the nature of the beast. Okay. So the thought process is, and I know this can get really complex really quick, so I'm just going to try to simplify it. This guy's cooties are his cooties. He's not allergic to his own cooties. He's allergic to everybody else's cooties. So when you're working with him and you take your gloves off, because we don't want gross contamination, but when you take your gloves off, all you have, because you washed your hands first, are his cooties. So, you know, anything that got through the gloves would be his own cooties. Does that make sense? So yes, there is a point where clean crosses to dirty and dirty crosses to clean. And it can be very confusing for students. So if you just remember, this guy's cooties are all his. It's okay to touch him with his own cooties. Okay, what we don't want to do is bring other cooties to him or take his to someone else. Good? Does that make sense? I know it can get a little bit confusing, but that's the best way for me to describe it.
Makes sense.
All right. So good on mouth care? Yeah, you don't have to brush everybody's teeth. Remember, it's always dependent on the care plan. However, I do want to say this. Not all nurses are going to get this right. Care plans are really complex things. I mean, to write a care plan, a really good care plan that's going to cover absolutely everything on that patient is complex. It takes a lot of time and a lot of thought process because you don't have to just find the real problems. You got to find all the potential problems too. So remember that nurses aren't doing this in a sound booth, right? They didn't lock themselves in a room that's quiet, right? Phones are ringing. Doctors are coming up to them and giving them orders. You're coming up with observations. Families are asking them questions. It's a very chaotic environment. Now, if they get sidetracked, they may forget something on the care plan. It can happen. We also have nurses that just aren't real great at doing care plans, and they forget stuff. Does that make sense? If you have a patient and you know that patient cannot brush their own teeth, and there's nothing on the care plan about they need their teeth brushed, you should let the nurse know, hey, there's nothing on here about mouth care. He's not doing it himself. Do we want to put that on the care plan? Is that something you want me to do? Remember, you cannot do it on your own. Because what if this guy has a huge fistula into his sinuses? We don't want you doing mouth care on that guy. Good. Can you imagine toothpaste up in your sinuses? Can you imagine how much that would hurt? Right? We don't want that. So you can't decide on, because you don't know everything there is to know about that patient. You can't decide to do mouth care on your own. But if you notice, hey, it's not on there, and I know this guy isn't doing his own, bring it up. I'll give you a good example of this. This just really made me sick. And when I was working, at a step-down unit. So this is after ICU, before you go to the regular floor. It's a little bit more monitoring than the regular floor, but not quite as bad as the ICU. We had a young guy who was riding a motorcycle and excessive speed, hit something, flew off, his head hit the tree, closed head injury. He also was paralyzed from the neck down. Actually, it was kind of upper chest down. And bad situation. And this poor guy, he was young. He had a million things wrong with him. I mean, a million things. And he was in the ICU for quite some time before he was stable enough to be transferred. Well, they were trying to get him a bed in a nursing home because his family all worked. There was nobody at home to take. He's now total care. He can't move. So somebody's got to turn him and do his mouth care and feed him and everything. So it was a really bad time for him. I felt so bad for him because he was so young, to have something like this happen, catastrophic. Well, when I went in to talk to him, I kept noticing that he would mumble his answers and he'd always turn his head a little bit away as he was talking. So I'm thinking, this guy's got to be depressed. I mean, this is a horrible thing that happened, changed his entire life. He's probably depressed. And I started talking to him and just kind of seeing where we were so that I knew what kind of a consult to ask for. And turns out in our conversation, yeah, he was depressed. I mean, it was a bad situation, but that's not why he kept turning his head. He had not had his teeth brushed since before the accident. And he was convinced that he had dragon breath and didn't want to offend anyone. This poor guy he has been through the ringer and he's afraid of offending me. I mean, really? The real problem here is that nobody had brushed his teeth in like weeks. So we ended up getting that taken care of for him. And I got a dental consult. It turned out that he had several teeth that had to be removed. Yeah. This guy's already been through the ringer and now we got to do this to him too. I mean, how horrible is that? So if if a CNA had noticed, hey, nobody's brushing his teeth, that's usually my job, I'm not doing it, and somebody had brought it to the nurse's attention, this guy could have been saved a little bit of heartache. Does that make sense? It's horrible. We can do better. Well, that was bad, but probably the worst one was a young woman who went through the windshield of a car, had glass in her scalp. Nobody took it out. No, I mean, yeah, like she was in the ICU for weeks. Nobody washed her hair. Nobody tried to brush her hair. Nobody, I mean,
Actually, now that you say that, when I was in my car accident, that's how I got this on my face. It was kind of the same, and it wasn't until I was more conscious and awake, and my mom had to have been there for them to have actually. There was still dry blood and everything all over me.
yeah, that's not right. We can do better than that.
Yeah.
We can do better. We should not be leaving glass in somebody's scalp for, days. That's kind of a common sense. I could ask a 9-year-old that and they'd give me the right answer. I mean, more lacerations. Yeah, absolutely. Absolutely. So if you notice if you see something, say something. Good. All right. So we just did this. So now let's go to respirations, page 54. Okay, nothing new to learn here. This is super easy, guys. Super easy. Look, this is all that's involved. We read the care plan, we do our opening, decide if we need gloves, we do our closing. I mean, there's nothing to this. Respirations is the act of breathing. So we're just counting their breathing. How long do we count for? Easy answer. Whatever's on the care plan. Yep, whatever's on the care plan. Easy answer. So for the care plan for this skill, it is going to tell us to count for 1 full minute, just like pulse. So we'll count for 1 full minute. This is not a hard skill at all. But it does require documentation. So we're going to kind of time out here for this skill. I'm going to go over this skill with you step by step, but I want to talk to you a little bit about documentation. Now, we did get into this just a little bit on Monday, so I'm going to kind of expand on what we learned on Monday. So we're going to come back to this in just a moment. But if you go to page 49 for me, 48 and 49. 48 is on documentation. 49 is on military time. So when we document in healthcare, we usually use military time, generally speaking, because healthcare happens 24 hours a day. It doesn't just happen between 9 and 5. So if I ask you to walk a patient at 7, I might mean 7 a.m. before surgery, or I might mean 7 p.m. after surgery. You need to know which one. 7 is not specific enough. So in healthcare, we usually use military time. Now, for me, I'm a very logical person. I'm linear thinking. And for me, military time just makes more sense. Because who was the bozo that said, okay, time, there's how many hours in a day? So we're going to count to 12 and then, I don't know, let's just start over. It doesn't make any sense to me. If there's 24 hours a day, let's use them all. So that's what military time does. You count to 12, and then instead of starting over, you just keep going. 13, 14, 15, 16. It makes more sense. Does that make sense? So to convert to military time, you simply add to the number. Okay. So add 12 to the number. So if it's 2 p.m., we add 12 to 2 and we get 14. If it's 6 p.m., we add 12 to the 6 and get 18. Or you could just keep counting, right? Just keep, if you look at the clock, 13, 14, 15, you can just keep counting. It makes more sense. Now, military time, there's no AM or PM. We got rid of that. Completely got rid of it. We also don't have a colon in the middle. Like if I told you it was 9:12 a.m., it would be 9:12 a.m. Or we got rid of the colon too. So for military time, it's 4 numbers all smushed together. 4 numbers all smushed together. So the hour is 2 numbers. The minutes is the other 2 numbers, all smushed together. That's military time. So right now, It is 11:32 a.m. if I used regular time. For military time, it would be 11:32. No a.m., no p.m., no colon, just smush them all together. 11:32. So that's pretty easy. If it were 11:32 at night, so let's pretend 12 hours later, we're at night now, it would be 23:32. Good. When you get back to midnight, midnight starts a whole new day. So it's 0000. That's where we start a whole new day. Okay, makes sense? So you want to be somewhat familiar with military time because most healthcare settings use it. I got a little worksheet there for you if you want to practice on your military time. For the test, you can use either. You can use regular time or you can use military time, but if you use regular time, you must put AM or PM. It's a requirement. So on the test, if you get assigned respirations and you have to document respirations, if you go to page 168, I think it is, try 168. Yes, I got it right. Okay, you can see where we're going to document. If there is a time indicator, you have to put, if you're using regular time, you have to put AM or PM. So like on measure and record, intake and output, you would have to put AM or PM. Does that make sense? Good. So let's talk about the other documentation principles. In general rule of thumb, CNAs don't document in words. Now, before I get a bunch of hate mail, before YouTube erupts on me, I do know there are some places that do require CNAs to document using words, okay? I said as a general rule of thumb. Some places do require word documentation. But usually, in most settings, CNAs are limited to just numbers. Because numbers are concrete. They're hard. There's no way to mess that up, okay? If you do have to document in words, there's some rules that go along with it. And wherever you go to work, they're going to train you according to their documentation standards. So you would have to be trained to document according to that facility. There's a lot of different documentation protocols. There's pie charting, there's SOAP notes, there's all kinds of charting by exception. There's all kinds of different charting methods. You would go by the one your facility is using. You have to be trained on. But there are some general rules that apply no matter what type of charting you're doing. The first rule is you never, ever, ever use whiteout. If you make an error, you put one single line through the error. You write error above it with your initials. Never scribble it out. Never use whiteout. Never use a Sharpie to obscure it. Basically, lawyers don't like things they can't see. If a lawyer sees something that was removed, redacted, they automatically think that it's something bad and they will come after you, right? So you have to remember we're dealing with lawyers when it comes to medical charting. So we don't destroy it. We don't scribble it out. We don't use whiteout. We just single line, error, and your initials. Never throw a medical chart away. So let's say that you're the only one that wrote on this piece of paper. You think you can take it out, bundle it up, throw it. You can't. It is a legal. It would be like going to the courthouse and throwing away a legal document. You cannot do that, even if you're the only one that wrote on it. Good. Most charting that's pen and paper has to be done in black ink, not blue, purple, red, or green. There are some exceptions to that, though. Go by your facility. But in general, black ink is preferred. Most documentation now is done electronically on a computer or an iPad or something like that. So most documentation is electronic now. So you'd be typing on a keyboard. So pen and paper doesn't really come into play that much. If you're going to document in words, limit your use of I statements. So you don't want to say, I found the patient on the floor. So that puts the focus on you, not the patient. So we've got to be careful about this. I would probably write, instead of I found the patient on the floor and I asked him how he felt or how it happened, patient found on floor. When asked, patient stated he doesn't know what happened. Notice I didn't put me anywhere in there. Does that make sense? This takes a little bit of work in your mind to figure out how to do, but we've got to get the focus on the patient off of us. Okay. Never, ever, ever use the term I think. You're not paid to think. You're not paid to interpret. That is way beyond your scope of practice. So you never, ever use the term I think. So if we've got a patient who is peeing nonstop, drinking a whole lot, complaining of burning when they urinate, and you wanted to document all that, you're going to put patient complains of burning, urgency, frequency. You wouldn't want to say, I think the patient has a UTI. We're going to keep it just to the facts at hand. What did the patient say? What do you see? Okay, facts at hand. When it comes to documentation, you never document for somebody else. Ever, 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 ever. If you didn't do it, you don't document it. This, I don't know if you guys know this, one of the largest drug diversion cases in America was right here in Spring Hill. This means a nurse was taking medications that were supposed to go to the patient and keeping them for themselves. The largest case of this happened right here in Spring Hill. So one of the ways that she got away with this for so long is she had other people documenting for her. She would tell at the end of the shift, she would tell the nurse coming on, oh my gosh, I forgot to document that I did this so-and-so. Can you document it for me? Yes. No, if you didn't give it, you don't document it, because now who's legally responsible for giving that pill? Yeah. You're saying I gave that pill and you didn't give that pill. That nurse took that pill, but you're legally saying that you gave it. That's right. That's right. So if you didn't do it, you never document it. You also don't document things before you do them. This happened in hospice. We had a patient. I really feel bad for this poor girl. I really do. So CNA is at the patient's bedside, long overnight shift. The patient is in the dying process. She's just trying to stay awake. And you have to document every 15 minutes, how the patient is doing. And she was bored. And I get it. I understand. She's trying to stay awake. So she just went through and pre-documented for like the next 2 or 3 hours, right? Just patient resting quietly in bed, no complaints. She's just trying to stay awake. I get it. But unfortunately, the patient died. And I got a form here that says, it's 3:30 in the morning, patient is dead. But I got a form here that says 6 o'clock in the morning, patient is resting quietly and comfortably. That's a legal document. So because of that, we had to get the medical examiner involved. Don't pre-document. If you didn't do it, don't document it, because it will come back and bite you. It will. Somewhere in your career, it will. And that turned out to be a really big deal. Really big deal. So be careful. So when you do something, document it when you do it. Be accurate. be brief, be complete, but never document something you physically did not do. Good? Do you guys know how to handle errors now? Okay, so let's look at one more thing regarding documentation. Go to page 115. So 115 is going to tell you about the team's method of getting shift report. So when you go on shift, when you're first coming on, you're going to get report from the outgoing shift. So the people that were there taking care of the patients are going to tell you a little bit about each one of those patients that you're taking responsibility for. This is called report. Now, there are certain things that CNAs need to know, like ADLs, basically. What do we need to know about the patient? So when you're getting report from somebody, it's helpful to have a very specific template to follow. The first thing that you need to know about every single one of your patients is how do they toilet? Because guaranteed somebody's going to have to go during shift report. That's like the first thing you need to know. How do they toilet? Do they get up and go to the bathroom by themselves? Awesome. I'm not involved. Do they need help to the bathroom? Maybe. Are we using a bedside commode, like a portable toilet near the bed? Do they need some help with that? Are they incontinent? Do we use a bedpan? How do we toilet them? So that's always first on the list. First thing you need to know. Second thing we need to know is eating, because every patient eats on every shift, and you need to know, are we encouraging fluids? Are we on fluid restrictions? What type of diet do they have? If I catch them eating Doritos from the vending machine, is that a problem? You know, what kind of diet are they on? So that's E. So T is for toileting, E is for eating. A is for the rest of the ADLs, mouth care, bathing, dressing, grooming, that type of thing. M is for mobility. Now, mobility is always a separate category because it's important. If we've got somebody who's supposed to be on bed rest because they just had a lumbar puncture or a spinal tap, we need to know that. We don't want to get them up to the bathroom if they're supposed to be on bed rest. So mobility is always a special category. And then S is for anything else that's special, anything else we need to know. So if you use this framework, you can very quickly get a good, concise report on all of your patients without missing anything. So Mrs. McGillicuddy here, she is a 69-year-old female who is here for blood pressure issues. She toilets herself ad lib. She eats a regular diet, low salt. She takes care of all of her own ADLs. You really don't have to do much with her. Her mobility is out of bed to the chair at least once a shift with assistance. And special, we're taking vital signs every 4 hours on her. So I can give you a report, everything you need to know on this patient in less than a minute. If we got 12 patients, it takes about 12 minutes. Now, if I don't follow any sort of a template and I've got to remember everything you need to know about this patient, we're going to be back and forth nonstop. This whole report thing could take 30, 40 minutes. So that's where the team's report comes in. It makes it super easy for you to relay information in an organized, cohesive manner. Good? So you can see a team's report sample at the bottom of that page. If you're working in long-term care where your patients don't change that often, these will be pre-printed for you. Because patients don't change. It's easy. If you're working in acute care, hospitals, rehabs, where your patients change all the time, admissions and discharges, and what we're doing with the patients change a lot, then you would have to write all this down. Okay. Good? Questions? Okay, so let's go back to page 54, and we'll talk about respirations. So nothing new to learn according to page 54. We know all the principles we need to know. So let's look at the care plan at the top of page 55 for this one. Care plan says patient will be lying in bed for skill. Count the patient's respirations for 1 full minute and record your reading. So how long are we counting for? Okay, that doesn't mean we can't take a shortcut somewhere else on another patient. Shortcut would be 15 seconds, multiply that by 4. But not with this one. I don't know why. Don't need to know why. Don't care why. Care plan says 1 full minute. I'll count for 1 full minute. Good? There's a couple of problems with this skill, though. We cannot tell the patient that we're counting their breathing. I can't tell you, okay, I'm going to count your respirations. Ready, set, go. That's right, because now your patient is aware of their breathing. It will automatically alter the breathing patterns. They'll either stop breathing or they'll start breathing fast. So you can't tell somebody, I'm counting your breathing. Ready, go. What we're going to do instead is tell them we're taking their vital signs. And when you say breathing is part, respirations is part of vital signs, yes. So when you tell them I'm taking your vital signs, respirations is covered, but they don't know which one you're taking, which means that they'll be a little more comfortable. Okay, good. Make sense? All right. So the other problem with this, not only can we not tell them that we're taking their, or that we're counting their respirations, we have to set this up so they don't feel like we're taking their respirations. I'll show you that in a minute and why that's important. In and out is counted as 1 cycle. So, right? Counted as 1 cycle. So it doesn't matter whether you start on the inhale, in between, or the exhale. It doesn't matter where you start counting, it counts as 1. Okay? So I can start on the inhale. I can count on the exhale, or I can count somewhere in the middle. It doesn't matter where. The whole thing counts as 1. Okay? So if you're starting to count respirations and the patient is exhaling, we count it. If we end counting respirations and the patient is inhaling, we count it. Good? Doesn't matter because the whole thing counts as 1. Make sense? Good? Okay. All right. So we're going to count as long as care plan tells us to, and this care plan says 1 full minute, record our reading. But if the care plan doesn't specify, we'll count for 15 seconds and multiply that by 4 to get our full reading. Normal respiration is between 12 and 20. So if we get 10, what do we do? If we get 22, what do we do? If we get 86, you probably ought to run. Okay. All right. We already talked about documentation principles. So let me show you something about this particular skill. Nope. Yep. All right. I need a volunteer to come over here and lay down. I know. There's always like one designated volunteer. Just go ahead and lay down on the bed for me, if you would. Okay. So if I'm going to count her respirations, you guys can kind of see this on the screen there. If I'm going to count her respirations, then I've got to make her comfortable, because if she's anxious, she's going to breathe a lot faster. Now, remember, I can't tell her I'm counting her respirations. I'm going to tell her I'm taking her vital signs. So I would, hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to take your vital signs. Is that okay? I'm going to close curtain, wash hands. Now I'm ready to go. Now, if I just stand over her, how comfortable are you right now? Not comfortable. No, most people aren't comfortable if you're a stranger, stand over them and stare at their chest. That is not comfortable at all. That really creeps them out. So we don't want to do that. That's going to cause them to become anxious. They'll start breathing faster. We're not going to get anything accurate. So instead, what I'm going to do is just hold her wrist. Now, I don't have her pulse. I'm literally holding her hand. That's it. Okay. I'm not finding her pulse, But I'm going to hold this here. This makes you a whole lot more comfortable, doesn't it? Isn't that weird? It's all psychology. It's weird. But you can't just stand and stare at somebody. So we're going to set this up so that it looks like we're taking the pulse and the patient will be more comfortable. So what we're going to watch is the tummy going up and down. That's where we're going to see the breathing. Sometimes it's the chest. Most of the time it's right here, like mid abdomen. You can actually see it go up and down. So if you look at her tummy, you might be able to pick up her tummy going up and down, but it's kind of a hard thing to see, isn't it? Now I'm going to show you a trick you can use to make this easier to see. So I'm just going to lay this here for a second. You see it better now? I just used psychology. I did not alter her breathing at all. What I altered was your ability to see it. So this is psychology, guys. Your eye is drawn to movement when it's a contrasting color. This is what kept us safe in the saber-toothed tiger days. Your eye is drawn to movement when it's a contrasting color. So this is a contrasting color and it's moving. So my eye is drawn to that. It amplifies it. Make sense? Okay. You can use this for the test. You can, we use alcohol pads because they're lightweight. They're not going to interfere with the breathing. But more importantly, they're mystical, magical, and medical. Patients are used to alcohol pads. They're nothing new to them. So when I just put this on there, all I say is I just need to lay that there for a second and she'll go, okay. It's not going to be a big deal for her. If she does ask me, what is that there for? I give her a non-committal answer. I'll need that later. And they'll go, okay. They don't push back. Now, if I put anything else on her tummy, she's going to ask, what's it there for? What are you doing with it? It's not familiar. Does that make sense? So we use alcohol pads for this because it doesn't interfere. It's a contrasting color and patients seem to accept it pretty well. Good. So what I'm going to do is this entire skill. I'm going to, actually, let me change this so that they might be able to see it a little bit better at home. Let's see what we can do here. Okay. All right, so I'm going to do this whole skill from beginning to end. I will simulate hand washing just for the sake of time. And then when I look at the clock and I say start, I want you guys to count the respirations until I say stop. Count them in your head, not out loud. Count them in your head. Remember that in and out counts as one, right? In and out counts as one. So I want you to count how many respirations. At the end of the skill, I'm going to document. I need to get a pen. Let me borrow your pen, please. I'm going to document, and then I will tell you what I got, and you can see how close you were. For the test, you can be off by 2 breaths in either direction of the evaluator's reading and still be accurate. Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to get your vital signs. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to close the curtain. I have clean hands. And I'm just going to lay this there for a minute. Let me see your arm. All right, this is going to take me a full minute, but I'll let you know as soon as I'm done. I will need you to remain quiet until I say, okay? All right, everybody ready? Good? Ready, set, start. Stop. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Call light is right there next to your hand. If you need anything, just hit that red button. Environment is clean. Bed is in the low position. I'm going to open the curtain. Patient is covered by clothing, so I'm good there. I'm going to wash my hands. I have clean hands. Document my reading and wash my hands again. After that, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. What'd you guys get? 13? Yeah, I counted 14. Oh, no, I did get 13. The last one, she was just inhaling when I said stop. So if you counted that one, it's fine. If you didn't, it's fine. 2 breaths in either direction. Still good. Good? Thank you. Any questions on that? Now, let's go back to page 23. I think it's 23. It might be 25. Nope. Sorry, I'm on the wrong. Uh, 29. Sorry about that. Nope. 27. Okay. I know it's in there somewhere. 27. So if you look on page 27, you see all of 27?
There's 25 when you put.
Oh, 25. Okay. 25. All the care plan sets. That's what I'm looking for. The care plan sets. What page is that? 25. Okay. All these numbers. Okay. If you look at page 25, all those care plan sets, look at how many have respirations on them. Respirations is the most commonly dictated skill. I think it's on 4 or 5 of those care plan sets. So it is the skill that you're most likely to get. Okay, you're most likely to get. So it's important that you understand that so you practice it. Respirations is one of those skills that nobody ever practices because you think you got it down. It's easy. Don't let that fool you. You need to practice this one. You don't want the first time you do any skill to be for the state exam. That's no good. You want to get every skill out of the way before the test. We will have some time to practice today in class. So I'm going to go over the test registration instructions now. We're going to get that out of the way. And then you'll have probably about 20 minutes at the end of class today to be able to practice. On Monday, you'll have about 30 minutes. On Wednesday, you'll have about 45 minutes. The following Monday, you'll have about an hour and a half. So, right. So the skills that we've covered so far. So as we go through the program, starting today, I didn't give you any practice time on class 1, 2, and 3 because you really didn't have anything to practice yet. So starting today, we've got a little bit of practice time. Okay, good. Make sense? And then as we go through, you'll get a little more practice time each class session. I talk a little less, you do a little more. Okay? All right. So let's talk about test registration. This is the packet. Go ahead and take one and pass it out, please. Thank you. All right. So I have complete test registration instructions on my website. You go to foryourcna.com under the testing menu, hit testing, you'll see test registration instructions. Now, I'm going to say that with a caveat here, okay? This should be okay for you guys, but I am in the process of updating my website. So if it looks a little bit different, it'll still be under the testing menu, test registration instructions. It just may look a little bit different because I'm trying to reorganize some stuff. So foryourcna.com, under the test menu, test registration instructions. And what I did is I did an actual test registration and videotaped it, screenshot it. So you can see me online completing the whole process from starting out with a Google search, what to type in, what to click on, where to go, how to create an account, how to create a super secret password, because there's very specific criteria it has to meet, how to verify your email, and then how to log in and fill out the form. Everything is covered in that video. Now, below the video, because the video goes kind of fast, I'm actually doing it. Below the video on that page is step-by-step slides. So watch the video first and then go through the slides as you're doing it so that you've got control over the timing. You don't miss anything. Okay, so I've got both up there for you to make this super easy. This is our process. So if you look at this paper, if you lose anything in class, don't lose this. This is the one piece of paper that you cannot lose because it has very specific information on it that you're going to need to register for the test. Okay, so don't lose this. But you can see here the 4 steps of test registration. Step 1 is to make a background check appointment. If you do not already have a level 2 healthcare photo-enabled background check, you're going to need one. They have to clear you for testing. If you have a level 2 background check for something else, like a concealed carry or working at a bank or a daycare or something like that, it's not going to count. It has to be for healthcare. If you're not sure, go get a background check. If you don't have one, when you register, they look for that background check. When you submit your registration, they're looking in the clearinghouse for that background check. If it's not there, this can delay the whole process by weeks. So you want your background check in the clearinghouse before you register. That simplifies everything. Good? When you register for your background check, you're going to need this number. So you'll see it's a gray box right in the middle. And it says use ORI number EDOH03380Z. When you register for your background check, you need that number. That is the routing number that tells the background check place where to send your file. If you don't have that, it's going to send your file somewhere else and they're never going to find it. So in Florida, all background checks are compartmentalized. We actually voted on this about 10 years ago. I don't know why we voted this way, but we did. They wanted to make all background checks discoverable. So that means if you worked in finance and you needed one for healthcare, they could pull it. Florida said, no, we don't. We'll do background checks for every industry separately. I don't know why, but that's how we voted. So you need to make sure that you're in the right bucket for them to find you.
How long do they last?
5 years.
5 years? Oh.
Yep. You also need to make sure it's photo enabled. Photo enabled. So when you go get your background check, they're going to do fingerprints, signature, and they're going to take a photo as well. Okay. Yeah, you might have one. I don't. There's no way no way for you to check either.
Oh, really? Oh, okay.
Yeah.
So I just got to do it again then.
Probably. But you'll need it for employment too. And they can pull. Employment can pull. So you only have to do it once. Okay, good? Good. So now up here, this is where we recommend that you get your background check. You can get them done anywhere. There's a million places to do a background check. But if you want to know where to go to get the background check, we have to go to prometric.com, nurse aid, Florida. This is Prometric's website. And under candidate resources, you're going to see FLDOH fingerprint vendor list. This is Florida Department of Health fingerprint vendor list. So this is a list of all the places that do level 2 fingerprints for the Department of Health. And there are hundreds. Some of them are mobile. They come to you. Some of them you have to register online. Some of them dropped off because of COVID. I mean, it's pretty convoluted. So I picked one that's in our area, and it is the most cost effective. And that's what I put on here. It's deontis.com. Okay. So this is the one I recommend just because it's cheaper than other places. The last class we just had, I had somebody contact me. She does mobile fingerprinting. And in order for her to come here and do your fingerprints, it was like $30 per person more. And I told her, I said that there's no sense in doing that. My students are cost conscious. So I'll just send them here. Okay. But there are other places if you don't like this one. But if you go to deontis.com, they have a new website now, so they're going to redirect you. But if you type in deontis.com, they redirect you. And you're going to click on one of two areas, doesn't matter which one. Up here, create an account, or down here, register. They both lead you to this form. And this makes you create an account. Now, this is an account for the background check, not for the test, background check. So you create your account, you verify your email, and then you go in to actually make up your appointment. Now, you can do a walk-in. This uses UPS store on Barclay. You can walk in. If you walk in, they charge you $20 more. If you register online, it's $20 cheaper, which is why I'm going through this with you, because I know $20 counts. It counts for me. I'm sure it counts for you. Okay. So I'm showing you the most cost-effective way of making this happen. So if you go to deontis.com, create an account, verify your email, you're going to click on Florida Services. That's where we need to go, Florida Services. And we need that EDOH number, the ORI number. We're going to put it here where it says ORI number. So we're going to type in EDOH 0380Z. And when we do that, it's going to bring up CNA by exam. Yes, that is the right one. So we're going to hit next. When we hit next, it asks us reason for request. We want other employment and licensing. This can get really confusing when you're looking at this. So other employment and licensing is what we want to choose here. And then it's going to ask us for an OCA. We don't need that. That's for employers, not us. Then we fill out all of our stuff. Name, address, phone number, social security number, what makes you you. You're going to fill all of that out. And once you do, it's going to ask you to put your zip code in to find a location close to you. So you will. You put your zip code in. And our closest one is in Spring Hill on Barclay. It's the UPS store. And then it's going to ask you to pick a date and time. Most of the time, you can get same-day appointments. It's pretty quick. Same-day appointments. And once you do that, you're going to come to your payment screen. And right now, it's $76.68. If you walk in, it's like $98. So it's worth your time to do the online registration. So right now it's $76.68. You'll fill that out, make your payment, and then go to your appointment. They're going to take fingerprints, a picture, and a signature, and they do not give you anything. This automatically gets electronically transferred to the clearinghouse. They're not going to give you it. You don't get your fingerprints to send anywhere. That's because of chain of custody. If you have access to your background check, you can alter your background check. So this is all done electronically. You have no influence on this at all, other than going to the appointment. Does that make sense? Okay. So once you go to that appointment, you can register for the test. I usually recommend you wait 24 hours, but once you're done with your background check, you can register for the test. Now, to register for the test, we're going to go back to prometric.com. The test registration form is this form. This is the test registration form. We can fill it out together and you can mail it in, but it takes longer to do that. The processing time is longer, about 2 to 3 weeks longer. If you go to Prometric and you do the online registration, which is all of this stuff, you're just going to type it online, it processes 2 to 3 weeks quicker. If you do this weekend, if you go get your background check and register for the test this weekend, you will be testing about 1 to 2 weeks after graduation, which is perfect timing. Long enough that you can practice, short enough that life doesn't get in the way and you forget. Don't put this off. I have lots and lots of students that take the class. They have every intention, but life gets in the way. And a year or two later, they call me up and say, can I re-enroll? Because I never took my test and now I really need it. But I can't remember everything you said. And yeah, I'll welcome you back into class, but you're going to pay to have that seat. And I don't want to take any more of your money. Okay? That's primarily why I do the live stream. Good? Don't put it off. You will forget. Life gets in the way. All right, so we're going to talk about the Prometric registration packet that you have in front of you, but it's located on prometric.com/nurseaid/FL. It's also on this sheet in the second column, so you know where to find it. Remember I said this sheet you don't want to lose. On the side, I want to point this out. On the side of Prometric's site is their contact information, but let's read this together. It says, if it has been more than 5 business days since you submitted an application and you have not received confirmation, please reach out to us by phone or email. Do you see that? This is on their website. They say if you don't get a confirmation within 5 business days. What's that? Right, almost a week. So if you don't receive confirmation, you should contact them. Here's what's going to happen. You're going to call Prometric. Hey, I haven't gotten a confirmation. I registered for the CNA exam. And whoever answers that phone, their whole job, they're minimum wage employees, their whole job is to get you off of the phone. They're not there to answer your questions. They are there to get you to hang up. So they are going to say something like, well, yes, it can take up to 90 days. What does Prometric's website say? How many?
5 days.
Louder?
5 days.
What are you going to tell them when they say that?
That the website says 5 days.
That's right. And the website tells you to contact them. And you now need a supervisor. Do you guys understand how that process works? The person that answers the phone is not there to answer your question. You need a supervisor. The only way to get a supervisor is to tell them what their website says. Okay, we're going to see this again in a minute because it's actually on the application itself. And that's approval within 7 to 10 days. So if you don't get confirmation in 5 or approval within 7 to 10, you have to call. So I want you to know how to contact them. One of these days, they're going to call me and yell because they're not easy to work with, guys. All right, so when you're looking at this paper, this packet that I gave you, okay, the first page we know we can't lose, right? It's kind of like our Social Security card. Don't lose it. The next two, these are all the places in Florida that you can test. You get to pick one. Anyone. Doesn't matter. Pick one. Now, the closest one to us is in Tampa. Actually, the one near the airport, which is at the bottom of that first page. Notice I put them in regions for you, North region, Central Florida, and South Florida. Okay, so at the bottom of the first page, you'll see Agilus International, which is our closest testing center. There is another one, though, on the other side of Tampa over by Busch Gardens, and that's the top one on the second page, where it's Veritas. You'll probably want to choose one of those, unless you want to go to Miami and jump on a cruise ship after you test. I mean, you can do that too. That's right. That's right. Okay, good. All right. So once we know where we want to test, so on Prometric's website, under application process, you've got two options there. You've got online and paper. Paper is what you have in front of you. That's where I got it. Online is if you want to register online. It's the same form, just online. Okay. That's where we find it. The paper application is the one I printed off for you. This is what it looks like. And we're going to go through this step by step. You don't have to fill it out here, but there's a few things that I want to bring to your attention that I do want us to fill out together, because otherwise it'll get a little confusing. Remember, I've done all of this in a video for you on my main website. You can go through the video for step-by-step instructions. But let's go through a couple of things here. So the first thing that I want to bring to your attention is the stop sign. And it says, please make sure that your name is the exact same on both pieces of identification that you're bringing. How many of you guys have a first name, middle name, and last name? Does anybody have two middle names? No? Anybody have three middle names? Okay, that's where it gets really confusing. If your last name is hyphenated, it can get a little confusing. Or if you have two last names, non-hyphenated, it can get a little confusing. So if you have a first name, a middle initial for your middle name, and a last name, this is going to go way smoother. I want you to look on, you don't have to do it now, but look on your photo ID that you're going to be using, whether it's a driver's license, a passport, a military ID. If it's a government issued ID with a picture, look at the name on there. And then look at your secondary form of ID. Secondary ID has to have a signature. So Social Security card, debit credit card, library card, something with a signature. Make sure the names match. That's what it's telling you. I can't overstate this, guys. At least twice a year, I have students who go to the testing center to test, and they're turned away because their IDs do not match. And you forfeit that $155. There are no refunds. So I can't overstate this, because if I have somebody come back to me and say, oh my gosh, they wouldn't let me test because of my names, now I can point back to this video and say, yes, well, I went over that. So I want you to be aware of this. I'm telling you, it happens once or twice a year. So make sure your name is your name. Below that, it's asking if you need any accommodations for the ADA Act, Americans with Disabilities. This would be like a seeing eye dog or a sign language interpreter or something like that. There's a whole packet of information you have to print off and take to your doctor to get authorized for ADA accommodations. And you can, the information is there. You can print it off. Okay. Below that, the first question says, have you taken the CNA written or clinical skills since 2002? Do I have anybody that was certified previously or has ever taken the CNA test? Okay.
I was, like years ago.
Before 2002? Okay, then it doesn't count. That's good. So all of you guys would check no there. And then you're going to start filling out your demographic information, your last name, your first name, your address, your race, your gender. And gender, guys, is your legal gender. Whether you have a high school diploma. So you're going to fill all of that out on your own. We're not going to do that together. That's all you. But I do want to come down here to this section at the bottom of page 2. This gets very confusing for students. If anyone has a felony in their background, if you have a felony, see me after class and I will help you on this. If you have no felonies, for number 1, check no, but leave A, B, C, D, and E blank. Do not check anything off. Just check no for number 1. Go down to number 2 and also check no. This is if you have no felonies. No felonies. If you have a felony, see me after class. Now let's go to number 3. Remember, leave your A's, B's, C's, D's, and E's empty. So let's go to number 3. So I'm going to explain to you what 3, 4, and 5 is all about, because the way they word this is very confusing for students. So let me explain to you what this is about. This has nothing to do with you using Medicaid as a user, okay, as a participant. This has everything to do, these questions have everything to do with Medicaid as a billing entity. So a doctor or working for a doctor's office. So unfortunately, there were quite a few doctors that fraudulently billed Medicare and Medicaid and made billions. Billions. And they shut those doctors down, but when they shut them down, they also said, okay, listen, you worked for this doctor. You now know how to defraud Medicaid. We don't want you working in healthcare ever again because you have the ability to defraud. Does that make sense? Okay. So if this applied to you, if you worked for a doctor who got shut down because of Medicaid fraudulent billing, you would have been taken to court along with the doctor. And they would, in court, tell you you cannot work in healthcare ever again, and you're going to be on a list of people who are not allowed to work in healthcare. That's what questions 3, 4, and 5 have to do with. If that scenario does not apply to you, you're going to check no on 3, 4, and 5 and leave your A's, B's, C's, and D's blank. Does that make sense? Everybody good with that? Okay, disciplinary history, which is the next section here. If you've been a medical professional in Florida or any other state, this is going to apply to you. If you've never been a medical professional anywhere, the answer is no to all of them. But what they want to make sure is you weren't a CNA in Indiana, knocked around some old people, got your license taken away, and now you moved to Florida and you want to do it here. So they're just asking, do you have any disciplinary action that has ever been taken against you in Florida or any other state? So then we go on to criminal history. This is pretty self-explanatory. Either you have one or you don't. The answers are yes or no. There is no maybe on here. If your answer is maybe, it's probably yes. The second question there has to do with having records sealed. If you've had a criminal history and you paid a lawyer $5,000 to make it disappear, they stole your money because we're still going to find it. And you have to check off whether you've ever had records sealed or expunged. The last one has to do with a juvie record. Do you have a juvie record? All right. Moving on to the top of page 4. This is all you. I cannot help you with page 4. I'm not allowed to help you with page 4. So you need to read each one of those questions, answer them, and put your social security number on there. You can do that on your own. We're going to go to page 5. So at the top of page 5, we have certification option / eligibility. Now, if we look back at this page, I told you do not lose. Right here at the bottom, I have important. You must select E3 Challenger as a testing option. Any other selection may prevent you from testing. I've gone a step further and I actually checked off E3 Challenger for you just so that you don't accidentally check something else. What do you have to check? When you go home and you transfer this information into the online application, make sure you check E3 Challenger. Okay? 80-something% of all CNA testing in Florida is done under the Challenger option. If you check anything else, it will probably delay or prevent your testing. Good? So I've already checked it off for you. I also put an X in the next section that says training information because it tells us to only fill it out if we selected E1 or E2. What do we check? Doesn't apply to us, so I X'd it out for you. Don't fill it in. If you select E3 on the application online, this will actually close up and go away. You won't even see it. If you select E1 or E2, this is going to require an answer, which we don't have. Okay, so if we go down a little bit more to test site information, I've already checked off regional test site because we're going to go to a regional test site to test. And it asks for your test site code. It says, okay, in the state of Florida, we have all of these testing centers. Where do you want to go test? We don't want to make you drive all the way to Tallahassee, especially if you live in Miami. Which one do you want to go to? Now, if you remember those first 2 pages we talked about, remember these 2 pages with our testing center list? Out to the side, right here, you have the code for that training center. There is a code. We're going to put our code here. If you're doing this online, it's just a drop-down box and you get to choose the testing center. But this box is so small, you actually have to put the code in. Okay. Good. All right. So remember that I've already given you the test center list. It's also located on Prometric's website. Under candidate resources, there's a test center list that shows all of the different testing centers in Florida. So we're going to pick one and put our test site code in there. Now we're down to fees. This is the important part. This is what everybody wants to know. How much is this going to run me? Testing fee is $155. It's paid to Prometric, not to us. That's their fee for testing you. It's $155, but you have a couple of options here. They're all $155, but you've got some options. So for most first-time test takers, we're going to choose the first one, which is the written exam in English and the skills exam in English. So just plain Jane test, what everybody chooses, super simple. But down below that, you see an audio option or an oral option. What that means is for those of you who English is not your first language, or if you have a learning disability, dyslexia, something like that, you can ask the computer to read the test question to you in earphones. So this is a computer voice. If you don't need it, it can be a little distracting and annoying. But if you do need it, it's very helpful. So choose which one you want. The first one is just your plain Jane test. The second one has earphones for the computer to read the test questions and answer choices to you. Now down here, a little bit further, about halfway down, you have the option to take the written test in Spanish if you want. So if Spanish is your primary language and you want the written test in Spanish, you have that option. you can do that. Same thing with the audio. It can read it to you in Spanish. So most people in my classroom choose the first option. Some choose the second. If Spanish is your primary language, you may want to choose one of the others, but I'm teaching you in English. So usually it's best to test in English if you're being taught in English, but it's a choice you can make. And once you select which option you want, whether it's the regular test, the oral through the computer, Spanish, once you've made your decision, there are a few other options here. These are for retesting. So if you failed the written and you have to retest, that would be for that. Once you make that determination, you're going to write 155 in the total in the column. And that's what you're going to have to pay when you submit your registration. So if you send this paper application in, the last page is our payment page. You can write in your credit card information. Now up here at the top of page 6, you've got a checkbox. That checkbox says that you have received these 2 pages at the very end of your packet. These 2 pages. This is the privacy policy. Tells them or tells you how they're going to use your information to clear you for testing. It's their privacy policy. You're going to check that box, says, yes, you got that. And you're going to read this, sign, and date. The very bottom, down here, very bottom, it tells us if we do not receive your emailed authorization to test, so your authorization, they say, yes, you're approved for testing. If you do not receive that within 10 to 14 business days, contact Prometric. Remember, when you call them up, they're going to say, oh, yeah, it can take up to 90 days. Don't call me all in a panic. Tell them, well, my application from Prometric says 10 to 14 days I should be approved. I want a supervisor. Good. And that's their contract with you, so they have to abide by that. All right. Now, we also have some cheat sheets on Prometric to help you. The candidate information bulletin is where a lot of the information that I give you comes from. You have access to that. It's right here on this website. You want to make sure you take a look at that before you sign and date, because it's got some testing information. I'm telling you everything, but it's on there if you want to review it. And then remember, you should receive your authorization to test within 10 to 14 business days. Now, once you submit your registration, about 3 to 5 days is what it's running right now, you will get an email from Prometric. That email will have an attachment. Open the attachment, because that's your specific information. When you open the attachment, make sure this is what it's going to look like. This is what your attachment looks like. When you open it up, it's going to have your information at the top. And then down here, it has application status. If it says complete, that means they've got everything they need. They found your background check, your application is good, and they got your payment. Everything they need to send to the Board of Nursing. It's complete. Now we're just waiting on the Board of Nursing to approve you. When the Board of Nursing approves you, you're going to get another email with another attachment. You're going to open it up. It's going to look just like this, but down here, it's going to say approved. That means that it's sent back to Prometric, and Prometric can now schedule your test date. So 3 to 5 days, you're going to get this that says complete. If it doesn't say complete, call Prometric because they're missing something. About 7 to 10 days later, you're going to get another one of these that says approved. If you don't get one of these that says approved, 10 to 14 days, you got to call. You will be scheduled for your test about a week from that point. So you'll get another email that has your testing date. That testing date will be about a week in the future. Now, the problem is that Prometric does not take requests. You're going to get a testing date assigned to you. You have no control over what they choose. You just get a date. But if that date does not work for you, you need to call them up and say, hey, that date doesn't work for me. Just say personal conflict or whatever. Don't get into details with them. Just that doesn't work for me. While you're on the phone with them, you will work out a mutually agreeable date. So let's say that you have transportation issues and you can only test on Saturdays or Sundays because that's the only day you've got a car available. You need to tell her, this Tuesday appointment doesn't work. I need a Saturday or Sunday appointment. And while they're on the phone with you, they'll find one that works for you. Don't wait until the day before you test, though. You've got to do this right away because I've got to have time to put somebody else in that slot that you're vacating. If you wait until the day before or 2 days before, they're going to charge you because they lost out on that slot. Make sense? Good? Questions? So you can complete this and mail it in. Perfectly okay if you want to do that. But remember, that delays testing by 2 to 3 weeks. You can take the same form, go online, and put all of this information in the online application, and that speeds things up a little bit. Good? And I've got a whole video that shows you how to do that. Let me bring this to your attention again. Remember, it's on their home screen. So when you call, you can say it's right on your home screen. I want a supervisor. All right. Open all emails from Prometric. Make sure you open all attachments from Prometric because your test date. Let me tell you, this happened to one of my students. She took my class in December. And in June or July of last year, she came to me and said, you know, I haven't got my test date yet. It was like 6-7 months. Didn't you get anything from Prometric? Anything? And she says, no, I never got anything. No emails, no nothing. You didn't call them? Oh, no. Well, she had sent in a paper application. And when they put her email address in, they did a typo. So they approved her for testing. They took the money out of the account. They sent her test date to the wrong email. She never got it. They don't give refunds. She missed her test date was back in January. And she didn't show up because she didn't know about it. But that's not Prometric's problem.
So when we do this, so they do the background check and stuff first. They wait till that comes back, and then you pay to schedule the test, or how does that work?
Do your background check, and then 24 hours later, you can register for the
What
test.
if there's like a problem? Like, what if you call? Like, what if you don't get the results back, and then you call them or something, and then there's like something that's delaying it or whatever? They're not going to have you pay for the test yet, and then just because that's delayed longer than the date that they scheduled you for, that's not going to be a problem.
Okay, so let me explain to you the process. So the process is in place to prevent all of what you just said. Okay, so we do the background check. The background check is sent electronically to the clearinghouse. It's actually instantaneous. I have you wait 24 hours just to make sure. Okay, so you do the background check. It doesn't go to you, it goes to the clearinghouse. You have no control over that. You register for the test 24 hours later. Okay, when you register, let's pretend I'm Prometric. Okay, and we're going to pretend you are the Board of Nursing. And we'll pretend you are the clearinghouse, okay, where all the background checks live. So you register, you go do your background check. It gets sent over to her. So she's holding your background check. You register with Prometric. So you register with me. I get your application. And what's your name? Tanya. So I get Tanya's application. I see it and I say, okay, clearinghouse, do you have a background check for Tanya? You do. Okay, I'm going to get that. I'm going to put it with this. I'm going to take your payment and put it with this. Now I'm going to go over to the Board of Nursing. I'm going to say, hey, I've got Tanya. She wants to test. I've got her payment, I've got her background check, and I've got her application. Can you approve her, please? So it's, and by the way, this is not an automated thing. This is an eyes-on human event. So that's why it takes a couple of days. It's not automated for approval. So Board of Nursing gives us your approval. It comes back to me. Oh, okay. So Tanya is approved to test based on the background check. Now, Tanya, I'm going to come back to you and say, okay, we got approval. We're going to schedule your test. Hold tight. I'm going to go over here to my computer, do what I need to do. A day or two later, I'm going to say, okay, we've got you tested on August 16th at this. So what you're describing isn't going to happen because it's not even going to get to that point. The application isn't processed until we have the background check. Now, if you get this back, remember I said we're looking for complete? If you get this and it says incomplete, you have to call Prometric because you got to figure out what's missing. Is there something wrong with the application? Is there something wrong with the clearinghouse? Is there something wrong with the payment? Something is missing. We can't get this to the Board of Nursing yet.
And that's going to be an email.
It's going to be an email. Yeah.
So,
Yeah. It goes usually pretty smooth. But when it doesn't, it breaks down spectacularly, which is why you need a supervisor. Okay. All right. Any other questions? Any other questions? All right. I broke this down just as much as I could for you. Remember, you always have this video replay. It started about 12:10. So when you go to the replay, go to 3 hours and 10 minutes in to get to this section. Okay. Plus, I've got the whole video on online registration for you with a slide presentation. Does anybody have any questions for me? Over the weekend, you have chapters 5 and 6 to do. 5 is on dementia. Pay attention to that chapter. You're going to have a lot of dementia patients. 6 is on skills. We cover skills in class. So I want you to read the paragraphs in between, but don't read the skills. We do those in class. Paragraphs in between, though. Remember your wrap-up email. You guys still getting the wrap-up emails? Okay, those wrap-up emails will help you. And let me get you your review sheet for today's class. Well, let me give you the. Thank you. You're welcome. These review sheets help you?
yeah. So number 15 was missing from yesterday, though. Did you know that?
Oh, was it?
Yeah.
Ah.
On the back of it. Yeah,
Okay, I'm sorry about that.
It's okay. I knew what it was, though. You know?
Sometimes
Yeah,
typos get
I
through. I'm a one-person team. So it's hard when you're doing your writing and your own editing because you see things that aren't there because they're in your head. So yeah, sometimes typos do. Thank you. Thanks for pointing that out. I'll take a look at that. I'll get them reprinted. All right. Any last questions for me? Those of you that want to practice, you're welcome to stay and practice. Otherwise, I will see you on Monday. Practice is not mandatory. You are free to roam. Have some fun this weekend. It's not all about school. I hope you guys have a fantastic weekend. All right, those of you that joined us online, thank you so much. Until next time, happy caregiving. Bye.
Are you the only one that teaches in this facility?
You've always been the one.